All right. Thank you so much. And thank you for allowing me to be here. So let me tell you a little bit about my story and what brings me here. So let's see. Well, I became a nurse, about 30 years ago. And the reason why I became a nurse was because my dad had open heart surgery and it was unexpected. And I was sitting there as a 13-year-old girl and I was scared to death. And I was sitting there in the intensive care unit and my father was really cold because when you have surgery, you get really cold because they try to lower your body temperature. And I was really scared. And this nurse came up to me and she held my hand and she explained everything to me, what was going on. And that was the moment at 13 that I decided that I was going to become a nurse. That was just a very powerful moment in my life. And I knew that I was going to become a nurse and nothing else. Well, of course, God had a plan for me. And so I ended up getting divorced, which happens sometimes. And I met my husband 9 years ago. And so we dated for about 2 years. And part of the situation was getting to know his mother. So his father had passed away before, and I was getting the opportunity to meet his mom. Well, it became very evident that my mother-in-law to be had some mild cognitive impairment. So I'm the CDP as a dementia specialist. So I'm a certified dementia specialist. And I noticed, of course, the signs and symptoms of mild cognitive decline. And so as we started the conversation with my husband, part of it was we noticed that my mother-in-law was going to buy a house here. She had a house in Little Rock, Arkansas, and it was close to his sister. What we noticed is that she was there and she was supposed to be kind of transporting back and forth and buying a house here in Austin to be near us. So she would be near, both set of grandchildren. But we noticed really quickly is that we needed to do something different because this wasn't working. She was able to drive where she needed to drive, but she wasn't able to, just the executive functioning was really off. It was just really off. And so my husband, before we got married, he said, so what do you think about maybe having my mom move in with us? And so, of course, me as a nurse, and I'm like wildly in love. And I was like, well, of course, I'm a nurse. We can do that. We did decide to buy a house with a casita. And so 3 steps out the back door, she was able to go up the stairs, and it was wonderful for 2 years. The only not wonderful part was when she would come downstairs, when she was starting to have some memory changes, she would come downstairs and ask if I was serving dinner. Are you serving? Well, yes, I was probably working 12 and 14 hours a day, and I would come home and she would ask me about serving dinner. But she's like this sweet little lady, and of course I couldn't get mad at her. But it became evident after my husband and I got married 2 years in that we needed to have a care transition for her. And it was getting to the point where we had care, and we have a caregiving agency, so we would have care up to 24 hours a day when we were gone and traveling, which isn't very much because when you're a business owner you don't travel very much, but it is important that you take breaks. So I always encourage you, so respite is very important. But it was a situation where we noticed that even 12 hours of care wasn't enough. And so what would happen is the caregiver, she was happy as a clam when the caregiver was there. And the moment the caregiver would leave, she would start knocking on all of our doors. Jennifer, Travis. I had been at work all day. The caregiver had fed her, and it was getting to be really hard. And it was hard for me. There was a lot of guilt. So I'm sure that there's a lot of people in this room that have had guilt. I hate that emotion. It's a terrible emotion because it doesn't do anything. So we knew we had to act because my mother-in-law was afraid. She was really, really scared. She didn't know where she needed to be. And she kept saying to me, Jennifer, I don't know where I'm supposed to go. I think I need to go back to Fort Worth because that's where home was for her. And so that was the moment when we knew that we had to make a care transition. And that's the moment that we decided to look for assisted livings for her. And we were able to, so that was 2 years ago. And now I'll tell you a little bit later about our next transition, which is going to be memory care. And that's the next thing that's on the horizon in the next 30 days for us. Go ahead. I have to look. Ooh, it's kind of hard to see. Okay. All right. A lot of you know this. I'm just going to talk a little bit about Alzheimer's disease. So Alzheimer's is the most common type of dementia. So a lot of you that are here probably do have a loved one with a diagnosis of Alzheimer's disease or a related dementia. So it's a progressive brain disorder. There's no cure for it. There's medications right now that we can, and please, if you're not affiliated with the Alzheimer's Association, I am on the board. I'm a proud board member. please see Faith. Alyssa's here. I don't know where she is. I think she had to zip out for a minute. She's going to be speaking later from UT. She's on our board as well. She's the chair of the board. Come see them. There's a lot of really great stuff that's out there medication-wise. So if you're not investigating what medications are out there for your loved ones, some of the medications are not designed for late stage. But for people that are early on and potentially middle stage, there are medications that you can start to take, not just Aricept and Namenda. So there are some new medications out there. So I would encourage you to talk to the Alzheimer's Association about that. There's different stages of dementia, middle stage or initial stage, middle stage, and late stage. And these are all some of the things that many of you are dealing with. I'm just curious, show of hands, how many people are caring or supporting someone with Alzheimer's or related dementia? Is it pretty much everyone? So the people that are not, what are you, just so I know who's here, what is your loved one? Does anybody want to shout out like what type of disease process or who they're caring for? Parkinson's. Anything else? FTD. Okay. Anything else? What was that? A stroke. Absolutely. Okay. So undiagnosed memory loss. Okay. Okay. Even PTSD. Anyone taking care of somebody that's PTSD survivor? A lot of similarities with dementia. A lot of things that are very similar and a lot of caregiver burnout. Go ahead. Okay, so let's start from here. So what are care transitions? So the first is transition from care settings. So it could be a home to needing care. So a lot of people here, just show me a raise of hands, who has like a non-medical home care agency that's supporting a loved one to help them age in place? 1, 2, okay, so maybe 10%. And there are a lot of barriers associated with that. I just want to highlight a few things. So sometimes we know we need help, and one of the barriers is that your loved one won't allow it, right? I don't need help, but they really do because they're walking and talking and they're able to participate and do, all of their ADLs. The biggest thing that we see is why, so safety is the biggest decision that I tell families when they come and meet with us, when they're asking about what makes someone appropriate for home care. So obviously we can, easy stuff, bathing, dressing, grooming, meal preparation, shower, all of that stuff. But medication reminders is one of these big things. And that was actually the start of the care transition for my mother-in-law. So one of the things, you have these little Medi planners, and it's funny, we're giving out Medi planners today. One of the big things, who has experienced when they do the Medi planner for their loved one, they either take all of their medications except for one. It's usually that tiny little pill that's shoved in, that they don't do that. I'm seeing some people, yes. Or they just forget to take a few days, right? Yeah, that could be a really bad thing. So if somebody has heart disease, they've got hypertension, they need their blood pressure medications, whatever it is, it can be a really big problem if they're not taking their medications. So that's one of the big times when people actually call our company, is that their loved one is not able to take their medications on time. That's executive functioning. So executive functioning means you have to be able to do things in an order. So when you go to the grocery store, think about how many steps or tasks that you have to do in order to prepare to go to the grocery store, get your list together. I mean, it's like 40 steps in order to go to the grocery store, get your groceries, pay for the groceries, and come back. That's executive functioning. It's the same thing when they have to take a medication. So of course, there's things like, ring a bell, Siri, Alexa, remind, but you've got to be able to know when Siri talks to you, you have to be able to know that, what do you do with that information? And that's executive functioning. And as people are changing in their ability and their cognitive ability, they may not be able to do that. And it's usually that tiny little pill that gets stuck. And that was what was the impetus for us. My mother-in-law would leave a tiny little pill, and it was a blood pressure pill, or she would just forget altogether. Or worse, she started taking all of them on the first day. Pretty bad, right? Pretty bad. Yeah. Yeah. And so, don't assume that your parent or your loved one is doing what they should be doing. Scary thing. That is a big safety issue. So coordination of care. So what we want to do is ensure continuous and integrated care during patient transfers. So some of the things that we see when a patient's coming from a hospital, So, I mean, everybody at the hospital, not to say anything mean about hospitals, but I mean, everybody gets all the information perfectly correct when they leave the hospital, right? You know, all the medications you're supposed to get. You have a pretty little list and it's always perfect, right? Because it's not. We know that it's not. It's not their fault necessarily, because a lot of times what happens is you come in with this big bag of medications, right? as a home care and a hospice nurse, they had this, you'd have like basically this big giant bag, and then they just the hospital is like, oh, I don't know what to do with this information. And so I would always recommend that you use medication reconciliation and you make sure and be an advocate for your loved one. So during these care transitions, when they're in the hospital and they have to go to a home setting, that is the biggest chance. That first 7 days after they come home is your biggest chance of readmission. So what does that mean? The biggest chance they have to go back to the hospital. And usually it's related to inappropriate either medications or not getting the medications that they need, which could happen. It could be that they really aren't ready to go home, or you may want to consider, you know, like a skilled nursing rehab or a post-acute rehab or something like that. So medication management. So one of the big things about that is that is a huge issue with medication reconciliation. And that just means that are the medications that your doctor order, are those medications are the ones that you're supposed to be taking? And what we see a lot of times, especially when I'm going into the homes, is we're seeing that it's not happening and it's not correct. Maybe the medication should be 2 pills, but they're taking 1. There just always seems to be an issue. And so that's one of those things as a caregiver and a care advocate that you really need to do. And obviously all the folks here are local, but you may not be, you know, you might be supporting a loved one that's in North Carolina. So my dad is actually, or somewhere else. So my dad is 91 years old. He lives in North Carolina. My mom passed away 7 years ago. And he literally still does his own lawn. And he refuses to get any help at this point. He's comes from a farm. He's, you know, grew up, his family was farmers. He was a construction worker. He does not want to help. He doesn't want help at all. And as a nurse, I'm like, oh, Dad, you know, what about, you know, because he had a stroke before. I'm like, Dad, we get some physical therapy. Nope, don't want that. Don't want those people in my house. So I have to deal with it too. You're not alone. You're not alone. And so for me, I have to give him, because his memory's okay and he's able to do his activities of daily living. I am, as a daughter and as a nursing professional, I am giving him the right to self-determination to make his own decisions. He wants to age in place where my mom passed away, and that's important to him. And so I want to honor that as long as I can. And I told him, I'm going to keep you there as long as it's safe. And if you're not able to do your own, you know, activities of daily living and you don't want someone coming in, then you're moving to, you know, Leander, Texas to live with me. So we'll just, you know, we call it like the old folks home, like our house. So care planning. So it's important that you work with either the professionals at the hospital, if that's good care planning from the hospital, working with them in order to make sure that it's a safe transition to home. If you are worried about your loved one coming home safely, you have the right to talk to the case manager and the social worker and tell them this is an unsafe discharge. And you need to tell them why. Don't assume that, you know, if you have a full-time job, or maybe you're in the sandwich generation like I am, so you are, you know, working, you have children, and you're also caring for an elderly person. So, you know, sometimes it's not feasible to be someone's full-time caregiver. That's where you may need to, you know, look at an assisted living, a memory care, a independent living, and maybe bring someone in for assistance or bring them to their home and get assistance as well. And so getting them to advocate for you. There's also senior advocates that you can work with. And I'll show you a few more information going through the Life Care Association. That's a good place for you to gather information and to be able to, you know, hire someone if need be to help you with this. Go ahead. Okay. So big challenges is communication, right? That's the number one issue is communication. Big issue. So it's usually about hospital, doctor's office. So let's say you have someone that's going to the doctor's office. So there's a person, like let's say your parent is in another state and they're going to the doctor's office. And you are not sure if the information that is actually being given out by the provider is actually getting back to you correctly. Because remember, if someone has memory loss or cognitive loss, they may not realize that the doctor said, well, yeah, you're on 200 milligrams of this, but we're going to cut it in half. And people do a really good job of faking it. Really good job of faking it. Highly intelligent people, we take care of a lot of professors from UT, lawyers, doctors, highly intelligent people can fake it for longer. Okay, so you may not even realize it at first. That's something to think about. And so there are agencies that you could hire. So if it's maybe, you're here in Texas and you have a loved one in North Carolina or New York or whatever, you can hire someone to become an advocate for you and to go to doctor's appointment with your loved one. They may still have mild cognitive impairment and fine, able to do their activities of daily living without a problem. But what happens is you may be missing pertinent information. And if you're only seeing them every 6 months, that's a problem. Because you don't know that huge decline. And I'm not saying when I say it's a problem, I'm not saying it's a problem because you're not there. I'm saying it's a problem because you don't know what's going on. And so there are opportunities for you to utilize an agency to help you with that. And again, that guilt is that terrible thing, and it makes you feel like you have to be there all the time. And sometimes that's not possible. It's just not possible. So that's why you may have to lean into another agency for that. Limited caregiver. So limited caregiver involvement. So sometimes what happens is that people have mild cognitive impairment. They go to the hospital and they're being discharged. And again, nobody recognizes that it's an unsafe discharge. So just be aware as a care provider, like as a caregiver, as a daughter, that if your loved one's in the hospital, if you can't be there, that's okay. That's okay. Just make sure you're having a conversation with the support team there at the hospital, like the case manager, the social worker, the nurse. And then there's also lack of family support. And, I'm sure that everyone in this room has amazing families and they support you 100%. And if there's, 2 siblings or 3 siblings, you guys divide the time completely equally. And everybody's on the same page and everybody, thinks that the plan of care should go exactly the same, right? Right? No. So no, it's the one that doesn't live here, that hasn't been here for 6 years, who lives in Arizona, that literally hasn't seen mom or dad in 6 years, and you're doing everything wrong. Right? Raise your hand if that is your situation. Right? Some of you are lying. Raise your hand high if this is a situation. Well, then most of you have really good families then. But most of the time that isn't the case. And we see that, in home care. Usually it's in hospice. That's when we see it most. It's the family member that lives super far away and hasn't been there for 6 years. And, why are you putting this person on hospice? And we can blah, 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 all of that. But you want to make sure that you're making people heard, because there may be a reason why they can't go. But for 6 years, that's kind of a long time. Just saying. So sometimes your family is not necessarily going to be your biggest supporter. It may be your friends. It may be this group. You may meet someone here today that you guys just hit it off. Going to respite programs. We have an amazing respite program that is here at Lighthouse, meeting amazing people. We now have a caregiving support group that we're doing. I think it's the 3rd Tuesday. Sharon's not here, but I forget what day. It's 3rd. Thank you. I'm hosting it. It's, I think, the 3rd Tuesday of the month. And we had close to 20 people with our first time. So utilizing these resources is really helpful. Just because they're family doesn't mean to be the one that you spend all your time with or you frankly listen to, because sometimes someone has to take control. Next, please. All right. So what do we do? Comprehensive assessment, very clinical comprehensive assessment. What does that mean? So you need to use your skills as the advocate for your loved one who knows your loved one better than anyone else. It might be your husband, it might be your mom, it might be your sister, it might be whoever, it doesn't matter. Use that as your first indication. Okay, you want to make sure that you are assessing the situation, and that if someone's in a hospital, that they're assessing the situation too. There are ways to have safety assessments. You could ask the home health agency to do a safety assessment before the patient comes home That's one of those things that you can do. Our company does safety assessments as well. We've done that all the time. We'll look to see, I don't know what it is about older people, but they love rugs. Like, what is up with the rugs? My mom would have all these rugs. I'm like, Mom, that's a fall risk. I don't care. I like my rug. I'm like, whatever. You're going to break a hip. Don't care. Okay, whatever. I don't know. I don't know what it is, but rugs. Medication reconciliation, caregiver education, which is why you're here with caregiver education. And then obviously discharge planning. Go ahead. We're going to get into the fun stuff in a minute. Okay, so what do? How do you be prepared? The first thing is you need to be prepared for a doctor's appointment. Okay, what does that look like? If you can't go and your person has mild cognitive impairment or they have something else and obviously need someone to get them and you can't go, you need to have someone go for you. And that's either you pay someone, you pay an agency, you have a geriatric care manager, you have a friend, you have whatever. You need to make sure the information that happens in that visit, you need to make sure that you are prepared to talk about it and come with a full medication list. Communicate clearly. Okay, it's important. So one of the things that I've noticed, and this is sort of an aging thing, is that our seniors and my dad, because he's a senior, 91, they always listen to the physicians or the providers as they are in charge, sort of superior. And I want to encourage you to come prepared because they don't have all the answers. They don't know your situation. They don't know what's in the home. There may be like a big giant dog that mom keeps falling over or something like that, or a little tiny dog that mom keeps falling over. They don't know all your situation. So you need to make sure, because what happens is when older people, the doctor will say, well, I think you need to do that. Well, yes, sir, that's what I'm going to do. But they may not know the full situation because they only have 15 minutes with your loved one or less. So listen actively. So what does that mean, listen actively? That means take notes. So for those of you who haven't gotten a cute little binder at our little, where Jennifer is, raise your hand, DDD. Hello, feel free. We have a bunch of those little binders. Bring yourself a little notebook to write notes down. Because I know I forget things all the time. Ask questions. Don't be afraid to ask questions. What I want to tell you is that you cannot come to a doctor's office with 50 questions. Because they're not going to answer 50 questions. They're not. Because they'll be going out the door and she's like, wait. You need to come, I would say, with your top 3 issues for this visit that we need to address. Top 3 issues or top 2 issues. Do not think you're going to be able to spend an hour with your provider unless, you are blessed enough to have one of those providers, unless actually 2 things. So if you have one of those concierge doctors, you probably will get an hour or more. So that's great. I'm a huge fan of them if you can afford it. There's also agencies that come into your home that provide like nurse practitioners and doctors that come to your home. You actually may get more like an hour. Okay, but have a list of your top 3 things that we want to focus on. Make sure you provide relevant information. So that's about medical history, lifestyle, medications, and try to make sure that your questions are answered. Okay, if you're not feeling like you're heard, you may need to, 1, get a different doctor. You may also need to, if that's not, in the cards or whatever. And just because, the doctors are busy. I mean, they're busy. Those providers are super busy. So what we want to do is we want to be pointed in our questions to them so that you feel like you have resolution. Because when you're taking care of a senior and supporting a senior, there are so many doctor's appointments, right? Like you feel like every single day you have a doctor's appointment. It's really hard. And you mix things up. Well, did he say I'm supposed to increase this med or decrease this med or what? I'm not even sure what I'm supposed to do. So you need to come and you need to write it down. Just keep it. My recommendation is I have people that are like amazing and they keep these big binders. That's a little too much for me. That's just too much for me. But just keep one little notebook that you're going to use just for this information. And then you can just date it and then write the questions and then write the answers. Okay. Next, please. All right, prioritizing concerns. So most important issues first: airway, breathing, circulation, things that have to do with safety. Those are things that are the big priority for you first. They are the ones that you need to make sure that you get addressed at that appointment. any medication changes, verifying medication list. You want to make sure, I recommend that you bring those medications to the doctor's office and you match up what the doctor's office has and what you are giving. And then when you leave, ask for an updated list of medication administration record, MAR, medication list, whatever they want to call it. So that make sure that when you go home, you can actually match it up, that it's correct. I'm telling you, you will find errors. I mean, there may not be errors that are that big of a deal. It might be, oh, I'm on a constipation medication or whatever, not that big of a deal, but it could be a medication that's a really big deal. A really big deal that could kill someone if it's not right. So I think being able to discuss treatment options and side effects of medications. And that's one of those things that makes it really hard because all medications, they interact with one another. Not all of them, but some of them interact with each other. So when you're making decisions about medications, it's important to understand the side effects. And I would tell you is use the same pharmacist. I'm sure you've heard this before, but use the same pharmacist. Go to your pharmacist when they're not super busy. So don't go on Friday afternoon. That would not be very smart. Don't go to Friday afternoon if you can. Go in a time that's not super busy and bring the medication list and make sure that they can go into the system and they can look to see if there's any drug-to-drug interactions. I almost guarantee almost every time there's one. And sometimes it's, minor and you guys can talk about it or whatever, but sometimes it can be major. So I would encourage you to do that. So also seeking second opinions. So, one of the things that when people are going for a diagnosis of a mild cognitive impairment, and that's a lot of our folks, making decisions about, when you get a diagnosis, I think that, there's sometimes it's hard, well, most of the time it's hard for someone to receive that information. And so I always recommend, like if you're talking about dementia, is that you go see a specialist that is like a memory disorder specialist, someone that specializes in this work. Like not just a general neurologist. Your general neurologist may actually diagnose this, but if you could go to a specialist, I think that's helpful. And they also will probably be aware of the more up-to-date information on medications. And there are new medications, again, out there for cognitive decline. Okay, go ahead. How are we doing time-wise? Okay, perfect. All right, so I just grabbed some people that will be speaking later. So this would be like family and friends. They're not speaking. I don't know where they are. I just got them offline. So Alyssa, she's on the board of the Alzheimer's Association. She's also a social worker, and she's in charge of the memory disorder clinic at UT. And Dr. Bertelson, he is speaking today. Faith, I don't know where is she? Faith, I don't know where she is. Okay, Faith. Okay. So Faith, there's a great support network for the Alzheimer's Association. And this is just a random person, but because I have so many people that I love in the area that I could put everybody's face on there. So I put a random person, care manager, senior care consultant. Doesn't mean you have to use this team. I'm just talking about in general. So your family and friends, so I put here family, but it could be friends. And sometimes your friends are more your family that you want to hang out than your real family. Of course. And then you've got, people that are a social worker. Someone came up to me and was telling me about, they have a diagnosis, their loved one has a diagnosis with dementia, but they are really struggling. They have mild cognitive impairment. It's moving along and they're struggling. And so that's why utilizing a care team so that they can help you. And maybe it's a situation where they get some therapy because if you're having mild cognitive impairment, and there are things like going to there's more people too I could add, like home health agencies, they can really help with speech therapy. So people are like, why would you do speech therapy? That sounds a little weird. Speech therapists can actually help with memory disorders. They can help to, help them write down things and help them, collect their thoughts and have to deal with, life a little bit better so they don't get so frustrated because it can be very, very frustrating. So I do recommend surrounding yourself. And the folks that are here, these are very, very good companies. And so I highly recommend, and I feel like, oh, there's another one in the next slide. I feel like you definitely need to talk to the people and find the agency or agencies that work best for you because you want someone that's on your side and that's advocating for you. Next. All right, so respite care. So how many here use the respite care for their loved ones over down there? Anybody? Nobody? Yes, one. Thank you. Two. Okay, three. Anybody else? Okay, They had like about 7 people down there. So this was something that was really important when Sharon and I talked about, me assisting her with the GPS conference. And I felt strongly as a caregiver myself, I understand that when you say yes to something, you say no to something else. And I know there's a lot of things as a caregiver that you have to say no to. This is the type of education that you really need to say yes to. So something's going to resonate today with you, or you're going to meet a person and they literally could be, your lifelong friend that for the rest of your time on this planet that you guys are inseparable. You never know. And so this is an opportunity and why we really believed in the respite and allowing you to be here and your loved ones to be well cared for. And so taking breaks, and I don't mean just going taking a bath. I mean like scheduling breaks in your life if you are the full-time caregiver. If you have a situation where your loved ones, they're living with you, and maybe you've got siblings that are really not involved. Again, none of you do because you said your families are perfect, but in the off chance that they aren't, that's why agencies can help you. That's one of those things. But one of the things that I can tell you is that we've all, even in my situation with my sister-in-law, I hope she doesn't watch this now, with my sister-in-law, she gives what she can, right? And sometimes your family members, they give what they can. And that can be upsetting and frustrating for a caregiver because you wish that they would take on, we'll just call it we don't want to use the burden, but we know that there is burdens associated with it. But I always tell people that sometimes what our loved ones give is what they can give. And emotionally, my husband and I are the ones that take the majority of care and support for my mother-in-law, and my sister-in-law struggles with it because every time she comes and sees her, it's just like a stab in her heart because she's starting to forget who she is. And so it's really, really hard to see that. And so people give what they can, and that those that they can't, we're just going to have to go around them. And that's okay. Asking for help, family and friends, agencies can help, attending support groups, and self-care activities. So if there's things that you really love to do and you're not doing, you need to make sure that you're whole as a person. We can't give from an empty cup. And that's why you're here, is we can't give from an empty cup. This needs to be an opportunity where that you recognize where you're struggling and what your struggles are, and recognize that it is okay. I am giving you permission to ask for help. I'm giving you permission to seek more knowledge and support from people. Next. Okay, so I put this is some amazing resources. Then we're getting into some fun stuff. So Kim and Mike Barnes, I used your picture. From Parents Engaging Parents, I saw more than 10,000, 14,000 people. So if you haven't gone on Parenting Aging Parents, their Facebook page, highly recommend it. It's a great source of resource. Keep in mind, I'll just say a caveat, anytime that you're doing those types of forums, there's lots of different people. And so sometimes that's a good thing for you to be on forums in general, and maybe it's not the right season. Would you kind of agree sometimes? And so, and give grace when you are responding to people or you're engaging. Give grace, because a lot of times people, they look behind, like online, they'll look behind and they'll want to respond to something, but it comes across a certain way. And just filter the things that you're saying. Make sure that you give grace to other people. Everyone's situation is different. And we want, like even today, to be a situation where people feel love and support. So Riverbend Church, Alzheimer's, Aging Life Care Association, Medicare.gov, age. So Medicare.gov, the purpose of that, so you guys know, is if you're looking for a skilled nursing facility, or you're looking for a hospice, or you're looking for a home health agency, if you go to Hospice Compare or Medicare.gov, you're going to be able to see the data actually on the facilities that you're looking at. Okay, so if you haven't done that, next. All right. I'm not going to go through a whole lot about legal and family planning because I want to get to some other stuff, but that is something that you need to seek guidance on. You need to make sure that you're having these conversations. I tell families the best gift. So all of you that have children, You need to remember this. The best gift that you can give your children is not money. I mean, they probably like that too. Well, they probably would like that more, but I think the best gift is the gift of communicating to them and having advanced directives, letting them know so they don't have to have the burden of making the decision for you. Because that is a very difficult place for people to be, to have to make those decisions. And I'm sure some of you are in those decisions now or just signed. Someone came up to me and said they just signed the DNR about their husband. That's a hard place to be. It's a hard place to be. So socialize this, have conversations, include your children and your grandchildren, the little kids. Include them in conversations. Do not make them afraid of talking about death and dying and decision making. Okay, don't make them afraid. We have to socialize these things. Because remember, the kids and the grandkids are the ones that are going to be taking care of us. So as my children, we socialize that. They know all about it. They know what mommy does. They know what dad does. They know what we do. So I'm not going to talk more about that because you guys can see one of the speakers, see one of the people. Okay, let's do fun stuff. So new memory loss. So who has a family member that's dealing with a new memory loss? Anybody? Okay. Oh, a lot of people. Okay. Oh, a lot of people. Okay. That's really challenging, I know, because it might be a situation where it's a mild cognitive impairment, but the person doesn't realize that they have it, right? Right? Because there's nothing wrong with me, right? Okay. This is where you need to start having those conversations with them if you don't already have advanced directives. So make sure that you have all the advanced directives and all the paperwork. Go see an attorney definitely at this time. Like unless it's too far gone. But if you don't have it, you cannot wait. You need to do it now where they still can make decisions. Because mild cognitive is mild. They can still, make decisions, but they have some mild cognitive impairment. So that's where this comes in. New memory loss. Have these discussions immediately. Please do. So do we need support at home? So I get this question all the time. So when do I need care at home? If that's where you choose to do. I always say safety is the number one concern. So can they be left alone? Can they do their activities of daily living safely? Can they bathe, dress, groom, meal preparation? Doesn't really have to do meals. You could leave meals for them. That's fine. Are they going to choke? That would be very bad. So that would be a problem. But medications, that is the big thing. And so people are like, oh, yeah, they can do all those things, but they can't take their medications correctly. If they can't take their medications correctly, you need a solution. Home care is a solution. There are other solutions out there. Maybe it's a friend. Maybe you're coming in to check on mom a couple times a day, or dad, or whatever, or you're helping your husband. But you need to trust and verify that those medications are taken. That is a big thing where I tell people it's time to get care. Rehab after hospital stay. I'm a huge fan of, depending on the situation, but I'm a huge fan of rehab after hospital stay, just because I feel like sometimes they started a new medication, they're unsafe on their feet, and they need some more strengthening. And they really do want to go back to their home. They want to age in place. The majority of people want to age in place. The problem is sometimes the cost to age in place, if you're doing it through private pay, is very expensive. And that sometimes is cost prohibitive for people. So I do recommend that if that's an option for you, there's rehab. So there's like a skilled nursing facility, and they do rehab. And then there's also like a post-acute rehab as well. And that's going to be more like a hospital, but it's like a degree down from a hospital. So I highly recommend that. Next. Do not resuscitate. So anyone struggling with a loved one about, when is it time to sign a DNR? Okay. Would you mind sharing your struggle? Yeah. Does everybody hear her? Yeah. So I'm going to try. So her loved one has some advanced brain disease, we'll just say that, but also has a lot of other comorbidities, heart disease. And what she was saying is that it feels bad to say, but she sort of wishes that he would just sort of stroke out and just go and not have to worry about not being able to swallow. And so that's where socializing this information before. And so in an ideal world, in a perfect world, and we don't live in a perfect world, that everybody will, as things are declining, as someone is declining, and whether it's age. So my dad, I mean, he's had a heart attack in July and he's had cardiac issues and blah, 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 all of that. But he proudly displays his DNR on his refrigerator every time I walk in. Saw my DNR. And all my information is on there as well, because again, he's in North Carolina and I'm here. And it's, because I'm his medical power of attorney, as a durable power of attorney, it's all on there. So if he were to, they walk in and he has been, he's unalive, he's passed away, they will not do, CPR on him. So I think that the first thing is starting the education. You can't at this point. You can't. Unfortunately, that ship has sailed. And so the question is, did he express to you in conversations growing up or while you were married or whatever, has he expressed to you or a family member what his wishes are? And that was, I don't want to struggle. So what I do is I look at, so if someone is advancing in their dementia, Alzheimer's, FTD, Lewy body, whatever, and you don't have a DNR, that's where you need to think about this. Like, we have life-limiting disease processes sometimes. Like, that, what that means is that if we were going to get someone back by doing CPR, are they going to be able to get back to the same quality of life? Yes, ma'am. Yeah, so there's an out-of-hospital DNR for Texas. It's a front and back page. The medical power of attorney or the person can sign, and then your physician can sign, and then you can also have, you could have witnesses sign, and you can actually, or have a notary sign as well. So I would, if you don't have that already, I would socialize that. It's a hard decision for a person to make, I understand, but if you have a life-limiting illness that is not going to get better, unfortunately, your Alzheimer's, your dementia, it's a progressive neurological disease. It's not going to get better. This is the time where you could, and you can always make a decision. Like, if you change your mind, you have that DNR, you can still initiate 911 and you can still rip that off. Just because somebody has a broken hip doesn't mean they're not, that doesn't, come into play. You know what I mean? And a lot of times that does happen. Someone breaks a hip. And so you do have to make a decision there sometimes too. And that's one of those decisions. Some of our hospice patients, they break a hip. And it's like, okay, well, what are we going to do with this? Are we going to do surgery? Can they withstand surgery? 95% of the time, they can't withstand surgery. That's why they're on hospice. So I would encourage you to have those conversations. And I would encourage you to, if things are progressing, I would encourage you to, if it's something you feel comfortable with, have a DNR signed. I know it's a difficult thing to do. That's why we're talking about it, but it is something that's very necessary. Because the last thing you want to do is, I always feel bad about that little old lady who's 101 years old, doesn't have a DNR, and we're, I hate the fact that we're cracking her ribs and those kind of things. Like, it's going to happen. It will, and to what, to what? Yes, please. No, you need to have an out-of-hospital DNR in Texas. Yes. You can find it online. You can print it out. You can take it to your doctor. You can also go to your attorney. Keep in mind, if you go to your attorney, they may give you an advance directives. That is not a DNR. You need to specifically ask for a do not resuscitate. But keep in mind, your doctor has to sign it. So you need to initiate it with your physician. Yes, ma'am. I think so, yes. Correct. There's an in-hospital DNR and there's an out-of-hospital DNR. And I believe it is based on the hospital. And it's usually based on that time you go to the doctor's or the hospital. And then choosing different level of care. So right now, I told you that my mother-in-law is in an assisted living. Well, my mother-in-law is becoming increasingly confused. She doesn't know where she is. I mean, she hasn't known where she was, but she really doesn't know where she is now. She doesn't remember that she was married before. She now thinks my husband is her husband. which is really weird. Let me just it's really weird. It's really weird. Ooh, yeah. Yeah, it's really weird. I'm not even going to go into it because it's just really weird. So we're going to be moving her to memory care because it's a better, safe situation for her. Okay, home health, palliative care, and hospice. How much time do we have? Okay. Ooh. Okay. Quick. Home health. Most people know home health, and because people get confused what these things are, and I probably should have put home care in there. Home health is skilled home health from Medicare or private insurance. It's helping you rehab. Thank you. Helping you rehab. So maybe you had a stroke or maybe you had wounds or whatever. They're going to help you. That's not going to be forever. PT, speech. I probably should have added home care. We'll pretend like it's there. Home care, that is non-medical home care. That is not paid by Medicare. Usually, some supplemental plans do contract with agencies. The issue with it right now is that the payment rates that they pay the agencies are so low. Most caregiving agencies pay their caregivers more than that, so that they can't do that, unfortunately. There's also with home care VA. So if you have a veteran that you're caring for, definitely come see us in the back, get a little form. You don't have to use our company, doesn't matter. But there's some amazing resources available if you are a veteran or your loved one is a veteran. And so we want to capture those resources. That could give you care 10, 12, 16, 20, even 24 hours a day if it's a really bad situation for the VA to pay for it. And that is something that, your veterans earned and you as a family member have earned. Palliative care, so that's pain and symptom management. You can have palliative care and still be getting aggressive treatment. That's totally fine. Palliative care means you're getting pain and symptom management, and that means you're focusing on making sure that, are you having excess pain? Are you having symptoms that are not being managed? Whatever it is, that's palliative care. And they can either come to the home, and there's even doctors that are in the hospital that do palliative care, and there's also doctors in the outpatient world that do palliative care as well. And palliative care is also done in hospice. So you've heard of hospice and palliative care. So hospice is a choice when someone is appropriate for hospice services, and it makes them so that they have, if the disease progresses the normal progression, would you be surprised if that person wasn't with us in 6 months? And there's certain determinations based on diagnoses. So for someone who has Alzheimer's particularly, if you have that as your hospice diagnosis, that means they're saying about 5 words or less that actually make sense. Now they might make sense with the words they're saying, but maybe it doesn't make sense on what they're saying. Like it's kind of gibberish, but it's 5 words or less, and that means they're incontinent of bowel and bladder. And those are kind of the indication that someone might be appropriate for hospice at that point. And then obviously different diagnoses, Medicare looks at it differently. And so, but we do have clients that are on hospice services for years. And that just means that they've had falls, infections, hospital stays, weight loss, functional cognitive declines, those kind of things. That's what makes someone appropriate for hospice. It is a goal of caring and not curing when you move to hospice care. Next. Okay. I want to leave some time for questions. Anybody have questions? No one? Oh, good. Goody. Okay, I'll go to you first. Do you want to stand up? Great question, because there are so many misconceptions about hospice. Thank you. So, biggest misconception is that, what type of care do you receive on hospice? So, there's a Medicare hospice benefit, and that all agencies have to abide by. And so that is nursing, social work, chaplain, volunteers, CNA, certified nurses assistants. It pays for medications related to their primary hospice diagnosis, any pain medication, any constipation medications, stomach medications, and what else? Supplies. So any supplies that are needed and any equipment that's needed. So Her question was, are you going to have a nurse like 8 hours a day? No, it's intermittent care. So when you have hospice, you have a nurse case manager that's in charge of your case. That nurse can come out anywhere from 1 day a week to 7 days a week, depending on what's going on with your loved one. They're usually there around an hour, but sometimes there's situations that are going on. We're trying to manage pain. We're trying to manage nausea or vomiting. And so there's different levels of care. I'm not going to go into all the details, but for general purposes that you're going to see your nurse about an hour visit, and it could be anywhere from, I would say on average, 1 to 2 times a week. The CNAs will come in to do personal care, and they're there about an hour too. And so they provide bathing and dressing. They'll do their hair, those kind of things, blow dry their hair, put their hair in curlers, whatever the care plan. And then you'll have a social worker that comes, depending on what the frequency is. It might be once a week, twice every 2 weeks, or every 2 weeks, it might be once a month, and then a chaplain the same. And the volunteers are amazing. I'm a huge fan. We have a huge bunch of volunteers at our hospice, and they're like musical volunteers. Like, they will play. I mean, it is the coolest thing ever. But a lot of people think that we're going to do shifts and that you can just rely on hospice to do shifts, and it's not. It's intermittent care. So that's why you use home care in combination with hospice care. Great question. Somebody else had a question. Let me go you next. I think they're going to be putting on the website. Is that true? Yes. They're going to be putting it on probably Age of Central Texas. So yes. Yes, sir. It's a good question. So he was talking about sort of planning for care. Is there a place that, knowing that she's Medicare, should be eligible for veterans benefits? Unfortunately, there's not a one-stop shop, unfortunately. I can tell you that from veteran services, obviously you can go to Medicare or va.gov, which I think is really hard. If you're looking for like care and support for like the aid and attendant program, you can definitely come see us. We have like a brochure. We have an intake coordinator that can actually help you fill out paperwork. There also is a place in Cedar Park called Heroes Night Out. If you guys haven't heard of them, they're amazing. So there's a gentleman that's a veteran that actually comes Tuesdays and Thursdays and will sit down for free with families and help them fill out the paperwork. There's a lot of services, and they know the services that are available. There's also those VA resource centers all over. There's one in Georgetown. Where do you live? Okay. You could probably, I know like Cedar Park has some, there's Georgetown, there's Austin, there's a whole bunch of, like, look up veterans resource centers. They can actually tell you also. There's so many services. Go ahead. No, it's a great question. I was just going to say, so I was just going to say, so
Bonnie, I'm the director of information and resources for Age of Central Texas, and that's what I do. I field those phone calls. So as you asked that question, I've got a list of like 4 people in my brain that do exactly what you asked originally. So yes, there are resources, and you can call Age of Central Texas and get connected to me, and I can get you connected to resources.
their card is in the back. See there, the green. Raise your hand. Hello, Roger. Doot, doot. Okay. And that's what I was going to say. You can also go to Age of Central Texas. So they have amazing respite programs. They have amazing information. They can connect you with people. The lending library, if you need equipment, just it's an amazing resource in our community. What else do we have? Go ahead. There's different programs. So there's different programs that do have income limits, all different programs. But the program that we do that's like free care for veterans, there isn't a limit. It's all based on what type of care that they need and where to go. So I think Age of Central Texas is a good place to start. It's a really good place to start. Roger's back there. Good place to start. If you're looking for the actual home care benefit, come see us, and we can help you with the paperwork for that. You do, just so you know, you need to have a DD-214 for a loved one. You also need to make sure that in order to utilize the veterans' benefits from home care, you need to see a VA doctor. That doesn't mean that doctor needs to be your primary care doctor and care for all of your care forever and always, but in order to initiate this care, you do need it. Well, I can tell you right now. So there are two veterans, well, there's multiple ways, but it depends on where do you live? Okay, you could choose. Cedar Park has one. You can call and make an appointment, say you want to, start care for your loved one. And there's also the Austin, which is the largest VA clinic. It's massive. Yeah, you may need to fill out some paperwork, work with them to get online and make sure that, everything that they're appropriate, like they have a DD-214 and all that stuff. But yes, they will help you. Well, and I think so, and I'll actually talk to, I think would be helpful next time is if we actually bring a VA expert for you. I'm not a VA expert. I think that would be a really good thing for us to do at our next conference. Or maybe we could do some type of virtual thing or something, because obviously that's a need. And it's something that I'm really passionate about because I think it's an amazing service. There's so many different services and I'm learning more. There's like a low vision program. There's all this stuff that I'm literally it's like an onion and I'm peeling the onion all the time. Last question. Oh, yes, ma'am. Yes. Yes, they will be able to help you. One more question. Come on, give me a good one. Yes. There are services. Yes. Yes. And that actually makes me think, I just want to say one thing. So the answer is yes. She said her stepdad and is the mom eligible? And the answer is yes for different programs. One of the things that I forgot to talk about was the situations that occur when maybe you are, so maybe we'll just say that the wife is caring for the husband and they are remarried and you have the daughter, son-in-laws. And so anybody ever have issues with those situations where the patient's daughter and son-in-law don't agree with the new wife caring for someone? We've had that situation before. But I did hear somebody told me a situation that it's actually going swimmingly well. And so it's been a really positive experience. But that is definitely a situation that can occur, that let's say you marry a person, they end up getting dementia or something, and then you're having to work with their children because the decision, and who's making the decision, because if there's a bad situation, like the siblings are probably going to want to make decision making. That's why early communication with your loved ones and having advanced directives, durable power of attorney, medical power of attorney is very important, especially if you've got friends that are newly married. Make sure that they go see an elder attorney and get that paperwork filled out, because you want to make sure that you don't have a situation, because we never know when something bad's going to happen to us. We want to make sure that we have everything in a line. All right. Well, that was the last question. Yes. There's a lot of them, all of the above. And there's aid and attendance where you can choose your own, and there's also home health aid services, aid and attendant. They give you money, and then there's all different situations and scenarios. One last question. That's the last one. Yeah. Dispatch medicine. They are speaking, so I would bring that up to Dr. Bertelson and Alyssa. I do not know the answer to that. All right, thank you guys so much. Hi, everyone. I just love looking out and seeing all of your wonderful faces. Thank y'all for being here today. My name's Faith Lane. I'm the program director at the Alzheimer's Association, Capital of Texas chapter. I have a lot of things in my hands. I'm going to share a lot of information with y'all. I wanted to keep my notes with me so I make sure I can cover it all because it's all good stuff. We're going to have some Q&A at the end, but we're going to dive in. Maybe. Here we go. Oh, bugger. Okay. Cool. Hit it. No. Yeah. I have a free hand now. Communication. Communication. Who here has had a challenging communication moment with their loved one with dementia? All right. Yeah. So, yeah, right. Communication is everything. It is all encompassing. Thank you so much. It is the core of that caregiving role. And so I think it's really important that we're going to talk about a few tips here. We're going to talk about navigating the different stages of Alzheimer's and dementia. We know that with this disease, it affects the brain, it affects our loved one's ability to communicate, it affects their ability to speak and listen, and it also changes some behaviors. So we want to talk about how we can communicate through those. So it works. We're gonna walk through the different stages of Alzheimer's, and we're gonna kind of navigate different communication challenges and some tips and tricks through those different stages. So we know in that early stage, you may or may not see communication changes at first. You may or may not, your loved one may or may not experience a big communication challenges up front, but some people might, and that might include difficulty with words, difficulty finding the right word, taking longer to respond, taking longer to navigate their way through a conversation. They might start withdrawing from conversations for a number of reasons, and they might really start struggling with some decision-making or problem-solving skills in that early stage. So whether this is new or not, whether these communication challenges are new for you and your loved one, this is a critical stage to really start having some of those conversations. I'm really glad Jennifer outlined earlier today. You know, she talked about what your loved one might want or need as they progress through this disease. Here's when those conversations need to be had. It's really important. This is also the number one stage of denial, right? This is where we don't want to have those tough conversations, but we want to try and work through some of those. It's really important to try to come to terms with the diagnosis and your emotions around that diagnosis, you and your loved one who is diagnosed. And it really helps to talk through those emotions with your loved one, talk through how it's making you feel. I bet you're both pretty angry about it, and that's the reality. So let's talk through that, and that might help open up some communication challenges or open up some communication channels as you navigate through this disease. Keep in mind, everyone progresses through this disease differently. So I'm going to map out early, late, middle stage information, but that could be different for everyone. In this early stage, there are some different ways to try and connect with your loved one. It might be different than how you used to connect, whether it's your mom, your dad, your spouse, or your friend. What's really important is to be direct. Let's not dance around. Let's get to the point. Let's keep things short and succinct, and let's get to the point. For example, if your person struggles to find the right word, if they're struggling to navigate their way through a conversation, ask them, do they want you to provide that word for them, or do they not? Let's find that out now in this early stage, what they want and how they want you to maybe navigate through some of these communication styles. Keep your sentences direct and straightforward to help that person avoid feeling like they're lost in a conversation.
get to the point fast, and that'll help with the conversation. And make sure to allow extra time for a conversation, especially those big important ones, right? Set the time so then you're not rushing through the conversation. You're really allowing your loved one to express themselves. And be sure to include them in the conversation, right? They're an adult. They have lived life. They have lived experiences. They can contribute. So make sure you're including the person with the disease in these important conversations. Keep in mind, don't make assumptions, right? Again, don't make assumptions about their ability to communicate. You know, maybe yesterday was one way, today's a new day. So let's try and engage your loved one and make sure that they're feeling included. Speak directly to the person. Ask them how him or she is doing that day. And let's start there, and then you can maybe gauge and change the conversation as you're walking through it. And be honest and frank about your feelings, your emotions. Don't pull away, especially if it's your friend who's navigating this. Sometimes we hear that from persons with the disease that, you know, their friends have stopped coming by, they've stopped checking in, and maybe it's been hard to communicate with them, and so they just stopped. But let's not. Let's still engage and stay active in your loved one's life. And also, this might be that early stage, might be a good time if it's you or your spouse who's navigating Alzheimer's and dementia. In this early stage, after you've had the conversation and everyone feels comfortable, this could be a good time to notify your friends and family about what's going on. We have some example letters over there if you want to learn more, but it could just be an email or a simple text saying, hey, we've been navigating some memory loss challenges. My wife or Diane was recently diagnosed with Alzheimer's, and we want you to know that. And if you want to have questions or learn more, please ask or visit the Alzheimer's Association. They can help you out. Okay. I'm rushing through some of this, and we'll get time for some Q&A at the end. So write down any questions you might have. That's a good tip across the board. Middle stage. All right. I broke my computer. Many changes in the middle stage of Alzheimer's or all dementias affect communication. This is where we'll see a lot of those communications changes happen. And if you notice some of those changes in the early stage, as we progress through the disease, you might see some of those become more pronounced, more challenging. We might see really increased difficulty in finding the right words. You might see them using the same words they know. You'll see them repeating that word more often. You might also hear new words. They might invent new words to describe different objects or situations, and that's always fun. We have a new word in our house, to morning, and that means tomorrow morning. And we use it now, and it's okay. You might see your loved one easily lose train of thought a lot more frequently than they might have used to. You might also see them speaking less often, you know, pulling out of conversations more frequently. They might also start organizing words in new ways and really having a hard time organizing words logically. They might revert to speaking in a native language. I heard a story recently about a woman who grew up in Germany, and she left when she was 3 years old and hadn't really spoken German since. And now, at the ripe old age of 82, she's now speaking German again, which is kind of interesting, right? That's a new thing to learn about your loved one. You might also start see them relying on gestures instead of words, so pointing or, you know, using big hand gestures so that they don't have to use the words that, you know, that don't come immediately to their mind. They might really start having some difficulty following TV programs that might have been your favorites, movies. They might not be able to pay attention to that full 2-hour movie. So something to keep in mind. Please note, I'm going to plug this a few times throughout this discussion, that Physical conditions and different medications can also bring changes. So if there's a big or sudden change that's come across really quickly that you notice, I would bring that up to a medical professional. You might want to check out, maybe it was a new medication or something happening on that side instead of the actual Alzheimer's or dementia. Or I'm going to bring this up a few times too, always check for a UTI. All right, so when communicating with persons in the middle stage, it's really important to approach that person gently, use all the cues. I like to identify yourself and come in at eye level with a soft tone. Introduce yourself, say, hey mom, it's me, Faith, your daughter, and put that label on it. And that just starting a conversation right there can just kind of erase that initial confusion and help guide the conversation more quickly and bring that person a little bit of ease and comfort to the conversation. Sometimes use touch, to let them know that you're nearby. That can reduce any kind of scared fear at the beginning of a conversation, and it can get their attention and can bring them that quick little comfort of a soft touch. Try not to criticize, correct, or impose your perspective. I'm going to repeat that because that's really hard to do, right? Try not to criticize. I will guarantee it will backfire most of the time. That person can often feel your tension and will just give it right back to you, right? But always remember to take the time to communicate. Give yourself and the person time to have conversations. Know that it might take a little bit longer than it used to have conversations about what's for lunch or the plan for tomorrow's doctor's appointment. Just make sure you carve out the time to have that conversation fully and engage your loved one. Y'all might have heard this before, but it's my favorite tip to join your loved one's reality. It's so important to step into their shoes, to figure out and assess what they're in the middle of. And it might not be your perspective. It might not be what you're understanding from your side, but step into their reality, try and see the world from their perspective. And you might gain a little insight of what they're needing or trying to communicate in that moment. The reality is they probably will not be able to see your perspective. They will not be able to see where you're coming from. And so it's your responsibility as care partner to step into their reality so we can navigate this, whether it's a challenge or just what's for lunch, in a better way. Try and listen and to figure out what the person wants or needs. That means paying attention to all the cues, maybe not just what they're saying, but think about the whole environment, what's going on. This is my favorite example. The words, I can still drive just fine. Who's heard that? Has anyone heard that? That's a loaded statement, right? And it's more likely not about the driving. What they're trying to tell you is, I don't want to lose my independence. And so let's validate that. Let's try and bring some understanding, again, from step into their perspective, step into their reality. What are they trying to communicate to you in that moment? One, it could be, I don't want to give up my keys and that's that, but also I don't want to give up my independence. I don't want to be solely relying on you for everything. So how can we communicate then in that conversation to bring some peace to it? Let the person know you understand. That statement right there can really start a conversation off in a helpful way. Yes, I understand. I see what you're saying. I wish you could drive too. I don't want to go to every grocery store trip with you either. I want you to go to the grocery store. Bring some humor to the moment, but bring that understanding to the conversation and start from there. Most importantly, respond to the emotion of the behavior or the emotion of the statement. For example, the person's communicating to you, and you can just say, you seem a little sad today. Do you feel sad? what's going on? And that might start a different conversation. You might be able to get to some underlying factors of the day. There's a lot of good kind of scenarios in here, but y'all know the scenarios, right? Y'all understand them probably better than any of these words do. Finally, after you've responded to those emotions, reassure and redirect the person by encouraging him or her to do something that might shift their thinking or behavior. It might be, I'm so glad I'm here with you today and we can have this conversation. Want to go for a walk? Or I was talking with a woman today and we were talking about redirecting, and she was able to kind of have a tough conversation and then redirect to watch a favorite TV show. And they were able to spend some enjoyable time together after that tough conversation. All right. Let's keep it slow and basic. Take your time and be patient while you communicate. The more you slow down, the less resistance you might feel from your loved one, because they won't feel rushed or they won't feel like they're unable to keep pace with the conversation. So try and slow it down. Rushing a conversation, especially important ones, often leave a person with dementia overwhelmed, right? And then they might become a little frantic. So as often as you can, try and slow it down, bring some peace to a conversation to try and avoid frustration. Use short sentences, basic words, speak clearly and directly, and remember at eye level, looking directly at them, treating them as a person in the conversation. Sometimes it's helpful to offer a choice if possible, but maybe it's kind of a leading choice, right? If you're having a discussion about mealtime, instead of what do you want for breakfast, you could say, it's breakfast time. Would you like eggs or oatmeal? Or I'm making an omelet. Would you like one? And that's very clear. That's simple, to the point. Give multiple cues. It's helpful to kind of walk through and give a person multiple cues as you communicate. You see me up here, I might throw my computer at one point. I'm a very handsy talker, but that's a cue, right? Try and give those visual cues and gestures, and that might help a person as you're having a conversation. If you're trying to get to a doctor's appointment, okay, it's time to put your clothes on. Let's load up. Let's head out the door, right? 2 steps, direct to the point, and I have those hand gestures to help kind of guide the conversation. Put your clothes on might be a little tough, but you know what I mean. It could also help to write things down for a person, reminder notes, calendars, labels, lists that can help remind a person where things belong, what needs to be done, who's who. Those kind of things can be really helpful, especially when communicating daily tasks or daily chores, and engaging the person in those daily chores is really helpful. Labeled photos. I think someone told me that one time that a person's ability to read was fading, so they did photos, and they had those all over the house, and that was able to help. The bathroom. Why don't you go to the bathroom? Pointing to the bathroom, and at the end of the hallway was a picture on the bathroom door of the toilet. And that was really helpful to help their communication style. Offer answers in your questions when possible. Kind of like I said earlier, I'm having an omelet. Would you like one? Instead of what's for breakfast, because what's for breakfast is an omelet. That's what we're going to have. When you need to, repeat your information, repeat your questions slowly, politely, not, I already asked you that. That's not what I mean. But would you like an omelet? And if there's no response, give it a breath. And then would you like an omelet? And see if there's another, if you have a picture of an omelet, that could be helpful on your phone. Would you like an omelet? Here's a picture. I'm going to try and make something like that. That could be helpful. Turn negatives into positives. I think that's our number one role as care provider, right? Turn negatives into positives. For example, instead of it's time for a shower, has that been a negative experience for anybody? Okay, so instead of it's time for a shower, let's get you cleaned up so we get to go see your grandchildren today. That's a very positive, or that might evoke a positive response for the person. Try to avoid quizzing the person. If you asked a question you're not going to get a different answer if you ask it 10 more times, right? Trying harder often just leads to frustration for you and your loved one. So let's try and be more respectful and helpful and give the person all the information that they need for the task. And if you can set reminders or different cues to tee that up, that could be helpful. But let's avoid quizzing or grilling a person for communication that you might need. Respond empathetically and reassure. Let the person know that you're there, you're listening, you're engaged, you hear him or her concerns. Those are valid to you. And remember that the facts are far less important than the emotion behind the communication. And remember, we're stepping into their reality, right? So whether those facts are your facts, that doesn't matter. We're trying to understand their facts so that we can understand and guide the communication or the task that we need done. Provide reassurance that you're together, that you're safe, and that you're there to help. Let the person know that you hear them, you understand their thoughts and feelings that they're experiencing the best way you can, and you're trying to find solutions or you're working together. As long as there's not a safety issue, agree and go with the flow. Okay, what does it matter if it's wearing a red shirt instead of a blue shirt? That doesn't matter. I say that a loved one I had, he was colorblind, and so the colors were always wrong to him, and so he loved to tell us it was a blue shirt when it was a red shirt, and we would fight about it. But what was the point, really? Sure, we're stepping into their reality. It's now a blue shirt. Cool. Make any adjustments to the situations that are necessary, and then redirect the person to another activity if needed and when possible. So in the late stage, as we progress through this disease, in that late stage, person now might only have a few words that they're using, but they still need to connect. They still need to communicate. That person has lost so many functions by that late stage that you might feel a really strong urge to do something every time, do everything. But usually it's your presence and that loving embrace, just knowing that you're there, that the person really needs. So remember that this is an adult person, again, who has lived a full life. They are someone that you love and treat them with that respect. That's really important to keep in mind during this late stage. You can connect with all different aspects of this person's life, and we like to do that through our 5 senses. So I'm going to go through some tips for you, thinking through those 5 senses. Connecting through touch, so your loved one might have lost those words, but there's still so many ways to connect. It might be bringing in maybe a favorite blanket or a favorite material. If they always wore flannel, let's have some flannel that they can kind of have that tactile experience with. Hand massages with some lotion is very relaxing. Identifying everyday items in a bag by touch. That's a fun game. Animals, the power of animals, a dog or maybe a farm animal if that's available to you. That touching, that stroking of an animal is a phenomenal tool. Molding clay or dough is a tactile experience that is helpful to a lot of folks. At the end of the day, holding their hand, just sitting with them, a nice pat on the back can really show that you're there, you're listening, and you're engaged with that person. Sight. Brightly colored pictures. Like I said, the pictures around the house of areas, words are really helpful, but also maybe laminating some family photos or just landscape pictures. Maybe y'all traveled together when you were younger. You like to go to France or Paris. Maybe you laminate some art from the Louvre together and you look at those together. And that's a great way to communicate. Watching birds or aquariums are a good activity to do. Or just going outside, sitting by an open window and looking at the trees. Right now is a perfect day for that, right? It's so pretty outside. We have our 3-4 weeks in Austin where we can go outside and have a beautiful day. We're about to enter those weeks. I'm really excited. Sound, the power of music, y'all, is so impactful, especially here in this late stage. Listening to familiar music, like a favorite band or favorite music style, sitting with your loved one, listening to that music can be just a wonderful way to connect. Listening to recordings of the outside. Maybe it's February and we can't go outside, but we can look at some pictures of maybe some places we visited. We can turn on some bird sounds or some burbling brook and just sit and enjoy through our senses that way. Listening to songs or speeches, especially in their native language, if they have one. Reading books, poetry, scripture, really just sitting with your loved one and you talking, right? The sound of your voice can be so soothing. Smell. We're walking through all senses, y'all. Smell. It's one of our most basic senses, and smell can bring back so many emotions, memories, thoughts. I don't know if I should say this, but I like to drink wine and I have this kit at home and it's a box and each box has tubes and it's different smells are in the tubes and it's supposed to help me drink and enjoy wine better. I don't know about that, but this is a great tool too for those with Alzheimer's and dementia, just to have maybe a box or some mason jars with different items that your loved one can smell. That's a great activity to do. Maybe it's fresh cut grass clippings, right? I love that smell. Or some flowers or hay or smells that might relate to activities that y'all did together or activities from throughout your life. Cotton balls dipped in essential oils, tea or coffee beans, or we talked about hand massagers earlier with some lotion. Maybe that's scented in a nice lavender smell. And so it kind of helps with all of those senses. Fragrant candles are also helpful if your loved one's not doesn't like a overly fragrant candle, but that can really help set the mood and set a nice environment. And taste. Yeah. Let's talk about our favorite foods, our favorite cookies, baking cookies, right? That can hit a few of those. Maybe you give your loved one a little bit of cookie dough to play around with. That's touch. The cookies are in the oven. There's some smells, and then you get to eat the cookie. That's a whole half morning of a wonderful opportunity to connect with your loved one with dementia. Also think about popsicles, flavored drinks, ice cream, all of those things. Just sitting with your loved one, experiencing these tastes that were a part of your life together can be just a wonderful, beautiful way to connect. Okay, so that was a lot of communication styles, right? Communication thoughts, ways to connect. So just a few things to keep in mind throughout the different stages. Understand what is and isn't possible by change, by understanding all you can about this disease, coming to these conferences, learning from AGE's website, from our website, from those information centers. That's so important on this journey for you as a caregiver. So thank y'all for being here today. But there's so many resources out there. So I encourage you to learn what you can, talk to your medical providers. And one of those 3 questions that Jennifer suggested, try and learn all you can about this disease so that it can help you navigate some of these communication opportunities with your loved one. Know and accept cognitive and functional limitations. Understanding those limitations can help prepare you and your loved one for how to navigate some of these conversations and some of these events that you're going to have to navigate. Remember to use feelings to connect and convey your mood through actions and tone of voice. I have to think about that all the time, right? Because I'm a very direct person and I come across saying, let's do this, this, and this. Okay, let me back up. let's do this, this, and this. You know, the tone of voice is so important and can really help your loved one feel more comfortable and engaged in a conversation. Demonstrate your caring to the person. Demonstrate your caring to the person and help you connect. Listen, observe, and try and decode what the person is communicating. Again, it's not always the words. Think about the behavior behind the words. Think about those emotions behind the words and step into their reality, step into their perspective. And that can help you get and gain more understanding and help you navigate some conversations. And know that communication evolves across the stages of Alzheimer's and dementia. And it's so important to keep that in mind because what worked last year, what worked last month, what worked yesterday might not work today. So we're going to have to keep evolving and putting tools in our toolbox so that we can navigate some of this. Okay, so understanding that behavior is simply a form of communication, right? I wanted to talk through some common dementia-related behaviors and how I can help you with some communication tools. And we're going to talk through some ideas here about some of these behaviors. But one thing, here's a little 4-step process we like to suggest. And I understand you're not going to have your loved one in front of you having a challenging behavior moment. You're going to say 1, 2, 3, 4. That's not reality. But I want to go through some behaviors, and we're going to go through 1, 2, 3, 4. And that's just kind of a rehearsal, right? So when you're in the moment of a challenging moment with your loved one, you might be able to think through some of these steps to help transition in an easy way. But our 4-step process that we suggest is, number 1, detect. Can y'all see that up there? Detect and connect. Step 2, address physical needs first. 3, then emotional needs. And 4, reassess and plan for the next time, because there will be a next time. When we're detecting and connecting, that's that first step to understanding and addressing behaviors. And I'm going to say this again, join the person in his or her reality. And that means seeing the world through their eyes. And that might help you bring some understanding to the behavior. When we remember that behavior is a form of communication, we know that if we see the world through their eyes, it might bring some understanding to why that's happening, because I'm using the very vague term of behavior, right? But we see this happening, but then if we're able to gain a little understanding and step into their reality, we might see why, when from over here, we cannot see why. But since they're the ones with the disease, you have to remember that we can't expect them to accommodate our needs, right? Instead, we must try to enter their world and connect with them where they are and do our best to decode what they're expressing. And sometimes we just simply cannot figure it out. We can't figure out where that behavior is coming from or what that person is trying to communicate. And that's the hard moment. But we're going to talk through some things with that and ways to intervene. Okay, so when we're detecting and connecting, we want to walk through the who, what, when, where, right? Who was present when that behavior took place? What was happening just before that behavior happening? What were you doing? What was I doing? What was little Timmy doing down the road? When does that behavior tend to occur? Is there a particular time of day? How did you react? How did they react? I also love journaling as a caregiver. I think that's so important. So when you're reassessing, maybe taking some notes, that might help you see that big picture that in the moment you weren't able to see. But journaling is a great thing. And I think Jennifer said she had some journals back there if you need one. As you're assessing, make sure you're connecting with that person. Maybe that's a soft touch, but approach that person with respect. Remember, at eye level, communicating directly, come at them from the front, not from the back, and use your body language to convey respect and a friendly approach. And they might respond a little more kindly to your tone and body language and all that. Second step, address those physical needs first. Are there any medical issues? Did we recently change medications? Are there signs of injury? And number one, possibility of a UTI. Let's check that out. That's often a cause in some bad behaviors or some new behaviors. In addition, behavior might change due to reaction to a new medication or interaction between different medications. And their needs may not be recognized due to the person's inability to recognize or talk through those symptoms. So that detective work is really helpful here to try and uncover some of those layers. And note any unusual behaviors or symptoms and talk to your doctor, especially if those are a sudden onset of new behaviors or a big change in behavior. You want to talk to your doctor about those. Think about additional causes of discomfort, right? Check those boxes: hunger, thirst, a need to stretch or move, a need to use the restroom. Is the room too dark? Think about their whole environment, right? Is the room too dark, too cold, too hot? Is that person in an uncomfortable position? Or is there too much commotion happening in the room? Think about all of those environmental cues. I do. Thank you very much. Physical needs. Okay. And during that physical assessment, while you're thinking through all these physical cues, continue to connect with the person, communicate, create that calm, soothing presence as much as you can. And that's particularly helpful in a situation of anxiety or agitation. Okay, then we're going to focus on emotional needs. Did I get it? I got it. Thanks. Think about how the situation feels to that person, not how you feel. Think about how they feel. And, that's usually the basis for a behavioral reaction. Focus on those feelings in your response instead of the facts. Avoid correcting people. Avoid telling them they're wrong and you're right. Let the person know that you're with him or her and that you're safe. And reinforce that you're there to help. Okay, fourth step, reassess and plan for the next time. The reality is some of these behaviors are going to happen. And so as you're navigating through your caregiving journey and you come across some behaviors that are reoccurring and you can do that detective work, figure out the cues and figure out ways to navigate that, it will make the next time easier, right? So again, journaling is helpful in this. But try to think through what worked, what didn't, was there an order in the solution that worked best? Was there an order of the solution that did not work and we should try again a different way? What happened in the situation that maybe escalated or created it to go sideways real quick? How do we stay away from those solutions and interventions? And think about what interventions were effective, what was not effective, and maybe how we can reapply those for next time. So now we're gonna talk through some common dementia-related behaviors, and I got a quick 15-minute sign back there, so I'm gonna talk through some of these quickly. But again, we'll leave some time for some questions. Whenever someone with dementia is restless, they're pacing. This happens. Have y'all seen this? Or maybe they're really distressed. They're excessively reliant on their care partner. That might be a sign of anxiety or agitation. So I'm going to tell you about Anne. And then we're going to talk through those 4 steps with Anne and her situation. So Anne is a 75-year-old woman with Alzheimer's disease. And she was pacing in the hallways of her house in the evenings saying, I need to go, very frantically. She would not stop. She wouldn't stop walking. She wouldn't stop walking for meals. She wouldn't stop pacing. And her family would give her sandwiches to eat while she was pacing. And that was the only thing that was working. She used a cane, but she started getting blisters on her feet and had really lost weight from not eating full meals anymore. Her family would ask Anne to sit down, but as soon as she sat, she would immediately get up and start pacing again. Anne worked for 40 years as a nurse at the night shift, and her agitation began every evening. Her shoes were so worn, she appeared to be in pain as she walked. So with Anne's story of agitation, let's think through those 4 steps together, right? Detect and connect. We're going to listen to the frustration and try and understand those feelings. We want to identify those triggers. It sounds like for 40 years, Anne worked as a night nurse, right? So her active time is probably in the evenings at nighttime. So how can we maybe think through her schedule now? We want to think about her surroundings. Let's ask those who, what, where, when questions, and check for sundowning and think through the challenges of sundowning. We want to think about, is this only occurring when certain people are in the room or when certain activities? Maybe it's happening after doctor's appointment. And so then her time in medical settings is kind of kicking in those evening times now after a doctor's appointment. First, we talked about her blisters, right? So we want to assess for pain. Those are step 2, addressing physical issues first. How can we assess for pain? Think about those blisters and make sure we have solutions for those blisters on her feet. And many times abrupt surges in agitation can result from pain from medical conditions like UTIs. So we want to think through if that might be the case. We want to make sure that person is hungry, thirsty, or lacking social interaction. You know, that can trigger concern with the person and escalate anxiety a lot of times. Constipation can trigger agitation, so make sure his or her diet has plenty of fruit and fiber, provide fluids throughout the day. And explore areas surrounding the person to see if they might have any triggered physical discomfort or distress. And then let's think through emotional needs. Acknowledge and understand that anxiety and agitation with the person. And I see you're really upset tonight. I understand you're frustrated. Why don't we sit down and have a chat, right? So we're coming at it face level, eye level, with respect and understanding. That's really important. Join the person physically. Walk with the person who's walking. And maybe just you being side by side of that pacing might calm the person down, help that person out. Use a maintained, calm voice and reassuring words. And if you can't make a change, if you can't change the situation that is causing anxiety, focus on changing that person's level of agitation by comfort or distracting her. And once that level of agitation is reduced a bit, then offer to engage in a soothing activity. If he or she is fearful, lonely, or sad, providing reassurance and companionship can help with that. And then step 4, thinking through a 4-step process again. Did your responses help? Did pacing with your loved one, did that make a difference? Did changing up mealtime, did changing up the schedule of the day, did that help with agitation at all? And reassess and make a plan for next time. All right. When someone with Alzheimer's or dementia is confused, he or she may not recognize familiar people, places, or things. When that confusion is combined with suspicion, they might start accusing someone, a loved one, of stealing, being unfaithful, things like that. And that can be really difficult as a care partner to hear. I have another idea with Anne. So when Anne's family comes to visit and evening begins, she becomes very suspicious that people are trying to get into her house and are watching her through the big picture windows. She becomes suspicious of her family for not making the people go away. And they all must be in cahoots with each other and they're out to get her, right? So let's think through our 4-step process here. Remember, number 1, detect and connect. We're going to try and stay calm and explore the situation with Anne. We're going to ask those who, what, where, when questions. And most importantly, we're going to step into her reality. She thinks everyone's in cahoots with her. So this conversation will go a lot more fluid if you agree and you step into that reality with her. You do want to check the environment for potential sources of confusion and try to discern whether the person is reacting to something in the present or if they're reacting to something imagined or in the past. If the trigger is current, explore how the person is interpreting the occurrence. For example, if the person has misplaced something, are they just worrying that it's stolen? And so maybe create a new way to track. If it's the phone or the keys or the remote, how can we make sure that that person is not misplacing that remote anymore? Maybe there's a tether to the couch, or the Velcro situation can help with that. But if the trigger is something imagined or in the past, try to talk to that person. What did that situation or occurrence mean to the person? Remember, let's get to those emotions of the event instead of the facts itself. Step 2, addressing physical issues first. So rule out any medical explanations like infection, low blood sugar, delirium. If the person is experiencing pain, see if you can intervene in a way that makes sense and makes that person feel comfortable. Assess for physical discomfort due to the environment. Is it hot, cold, overstimulated, things like that? Fatigue, right? Do we need to layer in some new nap times or some new sleep schedules if this is a reoccurring event? And modify the environment if you can. Mirrors are often a problem when someone thinks someone's out to get them and they see figures in the mirror and it's just your brother walking in the door, but they don't recognize that it's the brother in the mirror. So maybe removing mirrors might be something environmental you can change to help with this. Offer corrections as gentle suggestions or answers. Show photos, reminders when you can. If items are lost and no one can find them, maybe a solution is duplicating them, have multiples around. That can help. Remember that this is about diffusing the situation, not necessarily convincing the person of the truth. Step 3, addressing those emotional needs. Briefly let the person know that you understand he or she is upset and why they're upset, and step into that reality. Let the person know that you will take care of the situation. Reassure them. Make sure they know they're safe and that they can trust you. Use that calm voice, reassuring voice to talk through the situation. And step 4, reassess and plan for next time. Ask yourself whether any new responses helped. What did you change from maybe the last time this happened? Think through the process you took, the conversations you had, and how can you plan for the next time. Aggression. I want to talk for a little bit about aggression. Sometimes a person with Alzheimer's or dementia, I like this guy, can experience aggressive behavior, which can be verbal, physical, or both. There might be a trigger for this behavior. There might not be. So it's really important that we think through and prepare for this as caregivers. I have a scenario here, but let's just walk through some of these steps. If you can, try and identify the immediate trigger for the aggression. Did something frighten them? Was there a change that might have alarmed the person? Is there a logical response? Maybe there is, maybe there isn't. Or was it just an automatic reaction to something that a person might be perceiving? Ask yourself those who, what, where, when questions. Gently and calmly say the person's name, let them know who you are and that you're there to understand and you're there to help. Apologize. You know, maybe it was something you did, maybe it wasn't, it doesn't matter. The reality is their reality is that maybe you did something wrong. So let's go ahead and apologize and move forward with that. Remember, again, stepping into their reality, what's going on. Try and address physical issues first. Rule out any medical issues, any changes in medication, again, those UTIs. Limit and remove any distractions. Screen the environment for obvious triggers, such as loud noises, changes in the schedule, or something that the person might perceive as a threat. And be sure to protect everyone that's involved. Safety is the #1 key here. Screen for emotional triggers. That's step 3. What are those emotional needs? Screen for emotional triggers. Focus on feelings, not facts. The reality is your loved one is feeling a certain way. And so let's address those feelings very quickly. Usually, aggressive behavior associated with dementia is not dangerous. not harmful. You just need to react to the immediate situation and de-escalate. But I would be remiss not to talk about sometimes it does need to be escalated. And if safety is our #1 priority and 911 needs to be called, we encourage you to do so. When you have to make that call, make sure that you say, you notify 911 that the person does have dementia, and what the situation is. If 911 or the police come, again, remind them this person has dementia and make sure that that diagnosis is clear when engaging with law enforcement. If the likelihood is they would likely go to an ER situation, and again, make sure everyone is clear about the dementia diagnosis throughout that process. But they're here to help. And so if that it needs to be escalated to 911, we encourage you to do so. Also, a lot of local police departments, you can call and let them know ahead of time that there is someone with dementia at your address, and so that that's documented. Oh, I rushed through all of that. I want to leave time for Q&A. I think I can take 2 questions. Yes.
Somebody asked about recently passed legislation that says, when do licensed providers have to provide communications training to their staff for how to interact with residents with dementia or Alzheimer's? So is there?
Yeah, that was a big question. There was legislation that just passed this last session requiring memory care facilities to provide training to their staff around some of that. That might be what they were referring to. We also, the Alzheimer's Association helped pass legislation last year requiring dementia training for first responders. Age and I go out to APD for all the cadets, and we provide dementia training, but that's going to now be given to all police officers in Austin. So that's great. Well, all across Texas, they're going to have to start having dementia training. That's Texas legislation that just passed. Yeah, I don't know about other states. The Alzheimer's Association is here for you. Here are a few resources. If you walk away with anything today, please know about our 24/7 helpline. It is available 365 days a year, nationwide. If you have family or care partners across the country, they can call and get connected to local resources based on zip code. Also, our website is a great, I say it's like a rabbit hole of information. We also have a program called All's Connected. It's kind of like Facebook, but just for care providers. So you can log in and like old school chat rooms, chat with other care providers if you have questions about wandering or aggression or any of the things we just talked about. Also, All's Navigator is a wonderful tool. You can log in, you put in some of your information about your loved one, and it will pop out a wonderful care plan for you. Do I have time for one more question? Yes, ma'am. Mm-hmm. Mm-hmm. Yeah, that was a great question. She said, you know, how do I know when to Mhm. Mhm. Yeah. Yeah, that's a great question. So she said, you know, we talked through the different stages of Alzheimer's and different communication tactics through each stage. So her question was, when do I know when to transition some of my communication styles, when to change and evolve those styles? And I really liked how you pointed out, you know, respecting her abilities and where she's at. I mean, honestly, I think you talk to her about it and you ask her, especially in those early stages, if you can get this lined up and have a conversation about their wishes. I think that's really important. But, you know, ask her what her preference is and how she would like to engage with you on certain things. I think that is step one. But also trust your instinct and keep safety in mind to make sure. But that will help you. Keeping safety in mind, following your instincts, and keeping their preferences in mind, you'll be able to think through what's best for them. There's no one size fits all for any of this. We all know that, right? So trust your instincts.
It's an honor to be here. I've been practicing in Austin for 20 years now, and enjoy coming to organizations such as this to share my thoughts and experiences about Alzheimer's disease and other forms of dementia. So when we give presentations, we need to share where we get our money from, and so I am paid to speak for various drug companies. I work for UT, oh thank you, Texas Tech, and do a whole bunch of other things. So there are some kind of key definitions that I think it's important for the group to understand. We'll talk about that. We'll talk about Alzheimer's, other forms of dementia. What do I do in my office to make a diagnosis? And then we will talk about some of the older and some of the newer treatments. I've heard there's a lot of interest out there in some of the newer medications that we are prescribing for Alzheimer's disease. Oops, and I went the wrong way. There we go. So I hear this all the time. Someone comes in my office and say, I'm excited. I was told I don't have Alzheimer's disease. I just have dementia. Well, and I can hear some laughs out there. Many of you know that often people have both, that they have dementia caused by Alzheimer's disease. So it's usually something that goes hand in hand. So we don't just wake up usually one day with dementia or even with mild cognitive impairment. These are symptoms that progress over the course usually of years. So I think it's important to remember how do we start, and we start with the normal aging, normal cognition. But I put normal in parentheses because one can be truly normal with no symptoms, or one can have age-related cognitive symptoms. This is often difficulty remembering, oh, thank you, remembering words, occasionally word-finding problems, sometimes losing your train of thought in the middle of a conversation, or maybe misplacing things around the house. We all do, I do these things. We all do some of these things here and there, but these are by themselves aren't inherently a problem. It's important to know, however, that if someone doesn't think they have symptoms, it's not the same thing as not having any symptoms. So denial of symptoms, as many of you know who are caring for people with memory problems, very common to say, no, I'm perfectly fine. I'm not, my memory's fine. And yet everyone around them knows that memory and other symptoms really are progressing. So that's kind of the normal cognition. So what's mild cognitive impairment, or MCI? People with MCI have a persistent, this is how we distinguish that from normal aging, persistent cognitive problem. Memory, language, decision-making are mildly impaired every day. Usually this is short-term memory, and so we call this amnestic mild cognitive impairment, but it may include other cognitive areas. I generally don't diagnose MCI in people who have depression or anxiety or something. Neuropsychologists and psychiatrists might, but I keep a diagnosis of MCI relegated for people who have a neurologic cause for those symptoms. The key point to think about with MCI is people are functionally intact. They can still drive and shop and manage finances and pay the bills and whatnot, usually still live alone. So that's a key point to think about with the term MCI, intact daily functioning. Most of my patients with MCI are aware they have a problem. They may not want to admit to it. It may be very scary, but usually in the MCI stage, people know that there's a change in their thinking. Unfortunately, there's a relatively high risk of conversion or worsening when people have MCI to dementia. That happens about 10 or 15% per year. But some people never get worse, and in fact, some people get better. If their cognitive symptoms are due to over-medication or an infection or something else, treat that problem. Thinking, cognition can actually get better. And there'll be time for questions afterwards, so I'm going kind of quickly, so don't worry about taking notes or we're getting everything we're talking about here. So moving on to dementia, what is dementia? Dementia isn't a diagnosis in and of itself. Dementia is a syndrome. It's a constellation of symptoms that are usually characterized by, well, always by a decline in thinking, but so much of a decline that someone has functional impairment, can no longer drive, can no longer work, can no longer manage their home finances, no longer usually live alone completely independently. Dementia is not due to psychiatric problems. Dementia is due to a medical or neurological condition. And as we'll see soon, I won't show you all the dozens, but there are numerous medical and neurological explanations or causes for why someone might have, one might have dementia. So we consider, this is my sort of sad version of an umbrella. We consider dementia kind of an umbrella diagnosis, meaning it's a syndrome. A lot of things can cause dementia. Now, again, this is about as high-tech as I get, making that word bigger. But Alzheimer's disease is by far and away, the most common cause of dementia in really, certainly the United States and in most of the world. But we do have other causes. We have frontotemporal dementia, vascular dementia, and a bunch of other things that we'll show you in the next couple of slides. But I'd like to spend some time talking specifically about Alzheimer's disease. So Alzheimer's disease is, as you can see, if you trust me, but you can, that it's the most common cause of dementia in the United States. It's very, very age dependent, that only about 5% of people in their mid-60s and mid-70s have Alzheimer's disease, but that goes up to 13% from 75 to 85. And so by the time someone is 85 and up, 1 person in 3 has Alzheimer's disease. So it's very, very common with older years. And that really starts ramping up in the 70s and early 80s. So if you kind of clump everyone together in that sort of age range, 1 person in 9 over 65 has Alzheimer's disease. They may not know it, they probably don't know it, but 1 person at 65 has Alzheimer's symptoms of Alzheimer's disease, either dementia or mild cognitive impairment. The last point is actually a reason to have some hope, and I'll explain that later, but people who have Alzheimer's disease started having the disease accumulate changes in the brain, usually decades before developing these symptoms, 20 years, 30 years. This is something that's accumulating for a long time before we have symptoms of mild cognitive impairment or mild dementia. So this is what it looks like. This isn't my patient, fortunately for them, because this is brain samples. But these are slices. This is what it looks like on microscope. We have amyloid plaques over here and neurofibrillary tangles over here. So these are the characteristic pathologic findings that we see in people who have Alzheimer's disease. And as the disease progresses, we start losing nerve cells, and that's why people have symptoms, because nerve cells slowly die in the brain with Alzheimer's. We usually make a diagnosis when people are living, but that's an presumptive diagnosis. The only way still to definitively diagnose Alzheimer's disease is on autopsy to see in numerous areas in the brain these plaques and tangles, we call them. But with newer diagnostics, with newer spinal tap testing and PET scans, we are getting better and better at making a pretty solid diagnosis of Alzheimer's disease in life. So if it's not Alzheimer's disease, what is it? And one of the things I need to think about in my practice is what might be going on that might be fixable. Before we assume this is a progressive, relentlessly progressive disease, what might be going on that we might be able to change and turn things around? And the top one is medications. You know, it's one thing to predict a side effect to 1 or 2 medicines, but those of you who see the medication lists of yourselves or maybe family members, easy to see 10, 15, 20 medications. Very difficult to predict what side effects, what complications might come when you have this, what we call polypharmacy. So cleaning up medications is something that we try to do in conjunction with primary care to reduce the possibility of medication side effects. When we say metabolic disorders, we're talking about diabetes, vitamin deficiencies, thyroid problems, things that can be corrected usually with replacing of vitamins or or certain supplements. Sleep disorders are very common. You can sleep deprive anyone enough to make them look like they have dementia. And so it's very, very important that we ask questions about sleep to try to determine, is the sleep, what we call sleep hygiene, correct? And that are we going to bed when we should, waking up when we should? Are we using medications to fall asleep? Are we sleeping through the night? So a lot of relevant, important questions we ask about sleep. Depression can mimic dementia. The term is called pseudo dementia of depression. So people can be so depressed that they can look like they have dementia. And so it's important to look for mood possibilities when we're seeing our patients. Infections, we're usually talking about pneumonias or bladder infections. People can be very confused when they have these kind of infections. And brain tumor is one of the less common causes of cognitive problem. I only find a tumor in well under 5%. Usually well under 1% of my patients have their cognitive symptoms due to some kind of mass in their brain. So we'll talk about the non-reversible causes in the next couple of slides, but vascular dementia, dementia caused by stroke is one. You have a stroke, the stroke causes permanent damage, and that often causes permanent cognitive changes. And there are other conditions that I think are right here, actually. So vascular dementia is probably the second most common type of dementia, and it can be caused not only by a stroke, but by hemorrhage or by a term that I use, which I call it hardening the arteries. Some doctors call them mini strokes. Some the radiology reports use the term chronic microvascular ischemia, but it's basically hardening the arteries, and enough of that can cause cognitive problems. If one has strokes and causes dementia, we use the term stepwise decline. So people think normally, have a stroke, drops down thinking for a while, another stroke drops it down. So kind of the stepwise decline is what's the classic presentation of people who have multi-infarction dementia. Lewy body disease is very common. And when I throw names out, these aren't people I've seen, so I'm not breaking any violations. I haven't treated Robin Williams. I haven't treated Bruce Willis. We'll talk about him in a minute. But there are some famous people out there who have had some of these types of dementia. Robin Williams apparently had Lewy body disease. And this is a very common condition also. It causes prominent visual hallucinations, seeing people, seeing animals in a very prominent sort of manner early on in the course of disease. And people with Lewy body disease or LBD also have prominent night behaviors. In sleep, they act out their dreams. They can punch and kick and scream and really be very, very, often very violent when they are asleep. There's a little bit of appearance of Parkinson's disease also in people who have Lewy body disease. Next one, FTD, frontotemporal dementia. Bruce Willis apparently started having symptoms of aphasia or language problem, and they later announced that he had FTD. And I think I saw the other day that Wendy Williams, who I don't really know who she is, but I guess she's a talk show host or somebody, apparently announced also that she might have FTD. So these are things that you hear about in the press. So frontotemporal dementia refers to the frontal lobes or the temporal lobes as the areas where the disease are most prominent. People with the frontal part have prominent behavior problems. People with the temporal part have prominent language problems. And this is apparently what, again, Bruce Willis has. Symptoms begin with language or personality changes, may make inappropriate behaviors, remarks. And I'm not talking about inappropriate if someone's always been that way. We're talking about, because we may know people who have been inappropriate their whole life, and I can't really help you with that, I'm afraid. I know people who can, but that's not going to be me. So we're talking about new behaviors, new adverse behaviors, or new prominent difficulties with language. That's the language form. And I should have made those words too small. They often make unwise decisions about finances or other personal situations. And just in general, behaviors don't seem appropriate to the situation. But inappropriate comments are some of the early changes that I often see. So Parkinson's disease, I think most people probably know what Parkinson's disease is. It starts mostly with motor or movement problems, tremors. But if someone has Parkinson's long enough, they often will develop dementia. And it looks different from, Alzheimer's looks different from Lewy body disease. It's more of a kind of a planning and problem solving and a processing speed cognitive disorder. But again, it's very common if you live long enough with Parkinson's, you'll probably have some kind of cognitive problem. Creutzfeldt-Jakob disease or kind of it's mad cow. The animal version is mad cow disease, very rare, but very severe, and people usually pass away within a year of developing those symptoms. NPH, or normal pressure hydrocephalus, occurs when there's fluid building up in the brain, and that can cause cognitive problems, urinary problems, gait problems. NPH is one of the, although it's relatively uncommon, it's one of the important ones not to miss, because we can reverse it potentially with brain surgery, with a shunt. And so if someone comes in with, again, prominent cognitive and gait and urinary problems, that's something to think about. But before anyone gets too excited, you might want to remember that urinary problems are very common as we get older. Gait problems very common too. So we're talking about 3 very common symptoms that may not be related to the same condition. But again, it is something that we don't want to miss. Wernicke-Korsakoff syndrome up here is associated with alcohol use, but it's caused by vitamin deficiency, vitamin B1 or thiamine deficiency. And it can cause prominent memory problems, cause confabulation, where people kind of make up new memories. But again, it's not due to alcohol per se, it's due to the vitamin deficiency that can come from people who drink so much they don't get calories or they don't get vitamins through other sources. And there's mixed, just to make it more complicated, people can have 2 things at once. People can have some strokes, Alzheimer's disease. People commonly have Lewy body and Alzheimer's disease. So a mixed dementia is something that we need to think about as well. And again, that's relatively common too. So what do you do? If you're worried that you or your family member might have a problem with their thinking, see your doctor. And it doesn't have to be the first person to see is a neurologist, and it often isn't, and frankly, maybe it often shouldn't be, because we need to start with, I would say, with primary care to look at medications. They can get some basic tests done. They can often get a brain scan done. So it's important to start with, I would say, usually with primary care if you have one on board, to look for some of these more common problems. Psychiatry, or specifically geriatric psychiatry, are very familiar with diagnosing and treating Alzheimer's disease and other forms of dementias as well. So when you make that appointment, when you go to the appointment, please bring your medications. And also, please let us know what medicines are actually being taken. So I might get a bag full of medications coming into the office, but some may have dust on them. Some may be empty, have been empty for 10 years. So we need to know, it may seem kind of silly, but just because the prescription is there doesn't mean it's being taken at all, or maybe taken double. So again, we need to really sort out what's going on with the meds, and not just the prescriptions, but what supplements, what over-the-counters might be taken that might also have cognitive effects. And then please bring somebody, especially if there's really a significant cognitive problem. People with Alzheimer's don't know they're forgetful. I say they forget they're forgetful. And so it doesn't really help a lot if someone comes into my office and thinks they're fine, and there's no one in there to tell me otherwise. So it is important to have what we'll call a secondary historian. The test, the workup that we do has changed, and I'll tell you why in a little bit, but it's changed a couple of years ago. So the traditional kind of mechanism that we would follow to diagnose rather someone with dementia is we take a history, and most neurologists would say that's the most important part of the process. We ask, how long have there been symptoms? What were the first symptoms? What are the primary symptoms? What else is going on? So we can usually make a pretty accurate diagnosis just by talking with someone and getting a reliable history. But we do an exam, we do a basic medical exam, a neurologic exam, and some sort of cognitive test. It may be a 30-point cognitive test like certain presidents have said they took, or I'm not trying to be political, but they say that. Or it may be something more complicated, but we do some form of cognitive assessment to get some scores if we can, just to see objectively where we might stand. And then we do tests. We get typically a CAT scan or an MRI of the brain. We often do some basic blood tests. We may or may not get neuropsychological tests. This is 2 or 3 hours worth of detailed cognitive tests. And there aren't that many neuropsychologists in town, and it's not necessary for everyone, but sometimes they can be very helpful. So that was kind of the old way to do things before 2021. More recently, we still do our history, we still do our exam, we still do our basic tests. None of that has changed. All that's very important. But now we are starting to consider doing additional testing. We're starting to consider doing an amyloid PET scan, to look for amyloid in the brain. We're starting to do spinal fluid testing, and we're starting to also do genetic testing. And each of these has a role in someone who might have Alzheimer's disease, and it's becoming more relevant to think about why we might want to prove that. So this is a sample of a brain MRI that is just, it's a normal brain, but we can really see a lot. The MRI is the best test that we have to look at anatomy. It's got the highest resolution. As long as the patient's able to hold still, MRI really gives you a very, very good appearance of what the brain looks like. But it's not microscopic, so it won't tell you anything about amyloid or tau or any microscopic things, but it does do a nice job in determining if there's a stroke, if there's a tumor, if there's fluid building up. So it's pretty good in many ways. Yeah. So just briefly comparing MRI and CT. MRI uses no radiation. It's just a very powerful magnet. It's about 150,000 times as strong as the Earth's magnetic field. So a very powerful magnet. The CT does use a little bit of radiation, so that's a distinction. MRI takes longer. It takes about 10, 15, sometimes 30 minutes to do, whereas a CAT scan can literally take seconds. The prices become closer and closer. MRI is still a little bit more expensive, but there's not a big difference in price anymore. A big thing to think about with MRI is that there are certain implanted devices that are a problem with MRI, whereas pretty much you can do a CAT scan on anybody as long as they can fit in the CAT scan machine. And so CAT scan has very few restrictions in terms of who can you get a CAT scan on. This is a PET scan. A PET scan is one of the more advanced forms of brain imaging. It's more and more covered by insurance. It has historically not been covered very well, but just recently, a certain kind of a PET scan has become approved by Medicare, and it can identify amyloid plaque, and that's the one that was recently approved. The other one's been around for a while, looking at brain activity, and that's called FDG PET. That's been around for 20 years or so, covered by Medicare. So treatment, what do we do for treatment? And I don't put medications on the top of the list because, as you've probably heard earlier today, there's so much involved in treating dementia. It's not just medications. In fact, you've got to support family as much as the patient. You've got to consider a lot of things other than some of the older medications, which really aren't all that good. So education is where we start. We educate the families and patients about the disease. I'll talk about medications last. If there are environmental changes we can make, we do that. If someone walks into a room, thinks the tripod and the camera is a person, and it's shadowy, well, you move the tripod and see if that helps that belief go away. So try to modify the environment if you can to avoid having certain difficult behaviors. Creative arts and music is very powerful in terms of helping people be at ease with their symptoms. Having a structure to the day is very important. Many of us like structure, but a very organized schedule can really go a long way to help people remain a little bit more calm. And then there are other behavior modifications that we can think about that, frankly, our social workers and others are even better, much better at making certain suggestions than I am. The medications we see here really aren't all that great. They've been around for 10, 15, 20 years. They slow things down a little bit, but they will not stabilize the disease permanently, and people will continue to get worse. And there aren't many side effects to these medicines. These are all oral or pill. Where's my thing pointing? These are oral or pill or a patch form. So again, they're better than nothing, but they don't really do a whole lot of good. So what changed 2 years ago? Actually, 3 years ago now. In 2021, we started to have available what we call disease-modifying drugs for Alzheimer's disease. These have been currently infusions, IV drugs that are given. The first one was aducanumab, made by Biogen. And these are drugs that use the body's immune system to remove amyloid protein from the brain. And they do a good job at removing amyloid. The clinical benefits are not nearly as powerful, but they do what they're intended to do, at least in terms of removing this protein from the brain. Aduhelm is not the best drug. It never received full approval from the FDA for a number of reasons. And with newer drugs that are on the market, this one is leaving the market at the end of this year. And there are very few people out there that I know of on aducanumab or Aduhelm presently. So when we think about this category of drug right now, we think about Leqembi or lecanemab. And I know there have been questions about that because I've been told by several people today, that they're getting some questions about lecanemab. And so this was approved last year. It is covered by Medicare, so Medicare is paying for it. There's a drug coming out probably in a month or two called donanemab by Eli Lilly. And this is very similar in that it likely will be covered by Medicare, I would think shortly after approval. These are both infusions. Donanemab will be given every 4 weeks. Lecanemab is every 2 weeks, but they are infusions. Now, what we don't know is we don't know how long to treat. We don't know, do you treat for a year, 2 years, 3 years, whatever. That's a big unknown with an important unknown when we think about wanting to travel and needing to be available for this infusion every 2 weeks or every 4 weeks. So these drugs are also good at what they are intended to do, which is remove amyloid from the brain. They're probably even better at that than aducanumab. And they can blunt the rate of decline. So if you kind of slip like this steeply without the medication, the decline's more gradual on these medications, more gradual about 25 or 30% degree. But they can cause problems. They can cause a thing called ARIA, which is amyloid-related imaging abnormality. These are changes we see on a brain scan. Bleeding and swelling can occur from these medications. They are sometimes symptomatic, usually not, but sometimes symptomatic. So this is something that we, as the prescribers, need to be very close, pay close attention to and monitor for with repeated MRIs. And there can be kind of allergic reactions that can occur from these drugs too. So I've got a couple of visuals up here. These curves pertain to the drugs that have been looked at in this category over the past several years. And I'm going to be rude and turn my back to the audience. Or I'll just come over here. The people on Zoom can't see me for a minute, but I apologize. Okay, good. So we've got lecanemab, the purple line, the next one, donanemab. This graph demonstrates how well these drugs remove amyloid from the brain over the course of a year and a year and a half or so. 60 to 70% of people on this drug will have all measurable amounts of amyloid removed from the brain by about a year, 18 months or so. The older drugs, this one never got approved. This one is aducanumab. These drugs, the older drugs and the ones that's leaving the market, don't seem to be as powerful in removing amyloid from the brain as is donanemab and lecanemab. This is just another way to demonstrate the clinical benefit. The top line is the placebo. The bottom line is the drug line. And this one is lecanemab, and this one's donanemab. And basically what you see with both of these is that it takes, on the treated people, which is a lower curve, it takes longer to get to the same level of cognitive impairment as it takes for the placebo arm. So a way to think about it is if you treat someone for about 18 months with these medications, after the 18 months, they're about the amount of decline. I'm going to say this a little better in a minute. In the course of 18 months, you buy about 6 extra months of level of function that you wouldn't have had if you weren't treated. So it delays by about 6 months or so the amount of decline that you would otherwise have in that 18-month period. It's not great, it's not perfect, but it is a little bit better than nothing. This is what it can look like on MRI. I don't think there are radiologists in here, and if there are, don't tell me. But I think you can see that you got a bunch of white spots on this MRI over here. And this is one of my patients who was on drug. And all these white spots are fluid that's accumulating in the brain as a result of the medication. We stopped the drug, we did some treatment, some steroids, and over here, the white spots have largely resolved. Not everyone does so well. Sometimes there can be permanent problems, permanent deficits, but this is just put up there to demonstrate to you visually how much of a change can happen on the brain MRI in someone who is treated. And we're getting close to the end, I think. So who's appropriate for these drugs? There's a narrow window of level of symptoms to be appropriate. You've got to have either mild cognitive impairment or mild dementia. If the dementia is too severe, the drugs become clearly unsafe. One needs to have proof of amyloid in the brain through either spinal tap or a PET scan. And there are numerous contraindications. One can't be on strong blood thinners, anticoagulation for atrial fibrillation, for example. You can't have another dementia, or there's no point in treating with this medication. If there's been a recent seizure or stroke, brain tumor, for example, these are all reasons why one is not appropriate for treatment. And we do genetic testing also, not to predict the future of the family and not to diagnose Alzheimer's disease, but we do genetic testing because people who have a certain genetic profile are at a higher risk for complications from this drug. And to the point where we've stopped treating some patients with a certain genetic pattern because they've just developed too many of these complications. So this one genetic test, which you can get on 23andMe, and I don't have any relationship with 23andMe, you can get it from there, but you also can get it ordered through kind of a lab company too. It's not appropriate yet for people who have no symptoms. It stands to reason that that might be something to think about someday. It might be very exciting, for example, to use this medication, remove amyloid before people have any symptoms at all. But we're not there now, and I don't know if we will get there. But right now, one has to have some degree of cognitive symptom, but it can't be too severe. So there's a test that we often use called the MMSE as just one of the kind of bedside tests. And people need to have a score better than 22, or 22 or better to be considered for this kind of medication. So what's the future going to hold? I think, well, I know because this is happening on a weekly basis, amyloid PET scanning is slowly becoming more available and covered by Medicare, and I suspect it probably will be covered by the non-Medicare carriers eventually, but it is now finally getting covered. I think, well, I know there are blood tests that some are already clinically available, and I think one of these days blood tests may either replace spinal fluid or PET scanning, or at least be used as a routine screen for people who might have Alzheimer's disease. So I think we're going to see changes in the diagnostics in that way. Clinical trials are still looking at other anti-amyloid drugs. They're looking at anti-tau drugs and other sort of medications. And we're looking at other ways to get the medicines in the brain. And mentioned earlier that these infusions can be a major crimp in lifestyle if it's given every 2 weeks. And we're looking at subcutaneous versions of drugs. So you can get a kind of box of the shots, go on your trip and give yourself or give the shots to your loved one and don't have to be tied to the infusion center. And so this is, I think this would be a big deal in terms of just making it easier to prescribe and to access this sort of drug. So Alzheimer's isn't going away. In fact, as this curve demonstrates, as society ages, the numbers are only going up. They're going way up to the point there probably will be about double the cases of Alzheimer's disease in this country in 2050 compared to today. And that's a problem for many reasons. It's very expensive. It's a huge burden to families and societies. But we don't have enough providers as it is. We don't have enough neurologists. And I couldn't find any neurology numbers, but I found some geriatrician numbers. And as it is, in Texas and the US, these are the number of geriatricians in Texas, in the entire state of Texas, and in the US. And in 2050, if you're going to want to have 10% of geriatricians, 10% of patients get access to geriatricians, you're going to need 4 times the amount of geriatricians that we have right now. And I can tell you the training pathways, there's no way in the world training as it is going to keep up with that number. And if you want to have 30% of seniors have access to a geriatrician, you have to increase by a factor of 10 compared to what we have today. And again, there's the current training programs, there's no way they're going to meet those numbers. On the bottom section, we've got personal care aides. We're going to need, across the country, another 1.2 million personal care attendants, personal care aides in the next 25 years to provide enough support for patients and families given the increase in numbers of Alzheimer's disease. So I don't want to leave on a downer, and I think it's too late for that. But I think it's important to recognize that we need resources. We need more resources in really across the country to provide enough care for patients and families. Because as tight as it is right now, it is looking to get worse unless we do something a little differently. So just to kind of summarize, cognition slips. We go from normal aging, no symptoms, to mild cognitive impairment, and some people go on to develop dementia from there. Alzheimer's is the most common cause of dementia, but there are lots of causes, dementias that are out there. What did that say? Yeah. So the importance of making the right diagnosis these days, not only from a counseling standpoint and a planning standpoint, but there are some newer medications specifically for Alzheimer's disease that require a precise diagnosis. And I can't predict the future except that I do think the diagnostic tests are going to get better and more available. And I do think the treatment options will change. I see treating Alzheimer's disease like cancer was 50 years ago, like HIV was 30 years ago, in that we just had a couple of pretty nasty chemo drugs a long time ago when HIV was starting to be treated. The treatments weren't that good, but now we have multiple agents, we have polypharmacy, we have multiple drugs to use for cancer and AIDS that can really control those, at least to some degree, control those diseases better than they used to. So I might leave it here, but just, I know I've got a few more minutes. I do want to say that although there is interest and excitement with these infusions, they're not perfect by a long shot. They're not for everybody. There was a study that came out of Mayo last year, which suggests that only 5% of people in memory clinics might be appropriate for these drugs. And so I think it's important to be aware that the new treatments are out there and certainly try to get diagnosed as you can. But I think we need to have some realism in there as well, is that there are a lot of reasons why, and I tell patients every day that I see why they may not be appropriate for these drugs. So again, I don't want to be too much of a downer or anything, but I just want there to be a realism in terms of what to hope and what to expect. But I think the next 5 years, next 10 years, I really do think things are going to be different. Again, one more drug comes out in a month or so, many more drugs in the pipeline. And then I do think we are at the cusp of seeing better treatments, better treatments and more treatments for this horrible disease. So I think there's a break and we take questions after that, right? All right. Well, thank you very much.
In regards medication, can metoprolol cause metabolic encephalopathy?
So metoprolol is a blood pressure medication, usually used for blood pressure, sometimes used for tremors, not Parkinson's, but other kinds of tremor. I suppose if you drop your blood pressure enough, it can cause confusion. I wouldn't call that metabolic encephalopathy, but it could cause a confusional state. But metabolic things, again, like we talked about earlier, are vitamin deficiencies, thyroid problems, other chemical imbalances. So metoprolol would be a slightly different category, but it could look like it.
What role do microinfarctions play in dementia?
So a microinfarction is a small stroke or small infarct. And so I would suggest to the audience that some doctors might use that term more liberally than other doctors. Some, and you've probably seen reports like that too. I would say a microinfarction by definition is a small stroke. You have a small cavity in the brain. But some doctors look at the white spots, the hardening of the arteries that I alluded to and that I talked about earlier. Some doctors would call the hardening of the arteries, small strokes or microinfarctions. And technically those are different. Either way, they are vascular changes, vascular damage in the brain. So either way, regardless of which of those that they are, whether it's a stroke or the hardening of the arteries business, if you have enough of either one, you could have cognitive impairment, and you could even have dementia if you have quite a bit of either one, or if you have these microinfarctions in what we call high yield locations, like in a part of the brain that controls language, for example. A small stroke in one key area can cause significant cognitive problems.
I would just add that, you hear the saying, what's good for your heart is good for your brain. And the things that put you at risk for developing a stroke or a mini stroke also can put you at risk for developing dementia. And so, controlling things like not smoking, your weight, diabetes, cholesterol, blood pressure, all of those things are also going to help reduce your risk for dementia as well.
That was an excellent answer to segue into the next question. How can nutrition or diet make a difference? I.e., a vegan diet or no alcohol, pescatarian, Mediterranean diet, the mind diet. Yeah.
So there are a lot of healthy diets out there, a lot of unhealthy diets out there. I don't think there's a huge difference in terms of benefit to the brain between the mind diet, the Mediterranean diet, the DASH or the hypertensive diet. And just recently I read about one called the Atlantic diet, which is more kind of Spain and Portugal. But all these diets are similar in that they're, common sense. They're more healthy, less fried food, generally less beef, variable amounts of carbs, more fruits, more vegetables, less processed food. So again, if you have a diet that kind of hits those points, whether you label it this or that or the other, I don't think it makes a huge difference unless you have high blood pressure, because I think that's different. And then you don't want to have something with high salt that might raise your blood pressure significantly. But otherwise, I think they're all pretty similar. None of them will, I don't believe any of them will reverse dementia. There are some thoughts out there with a few that talk about reversing dementia due to lifestyle factors. I don't think we're there, but certainly it's likely that you could improve your chances in the long run, especially by following a healthy diet through most of your adult life.
I would add that hydration is also extremely important. Most of us are probably dehydrated. And so doing everything you can to try and get your water during the day is also going to give you more energy to do caregiving, and everything in moderation. I think extreme diets, making extreme changes or eating things you don't like for every single meal is not realistic, and that's not going to lead to a high quality of life. And so when I look at what we call the 6 pillars of brain health, things that can reduce your risk for dementia, nutrition is one of them. Some of the others we've mentioned: exercise, sleep, social connections. Choose one of those to focus on for a couple of weeks or a couple of months. Don't try and do everything all at once and make all of these changes. It's really impossible. Say, okay, for the next couple of weeks or months, I'm going to focus on my nutrition, and then maybe I'm going to add in, walking 10 minutes a day. And so taking those baby steps and not putting more pressure and burden on yourself when you already have so much on your plate.
This next question regards medications and vitamin supplements. Can vitamin B12 or any kind of vitamin supplement for that matter, or pretty much any other thing we see advertised on TV that is supposed to promote health, can that cause confusion or contribute to dementia symptoms?
You can probably take enough supplements to cause some confusion. I haven't seen that myself. The exceptions maybe are the fat soluble vitamins K, A, D, and E. Those you can take too much of. They build up in your adipose, your fat tissue, and so you do want to make sure you're not taking too much of those. But most vitamins are excreted out in the urine. One of my professors used to say that these vitamins that you see advertised on TV give you expensive urine, but that's about it. I think that a well-balanced diet, a good multivitamin, and a vitamin supplement, if it's attacking something that's proven to be deficient, I think that's adequate, but I don't advocate for really going further than that.
We have a diagnosis of MCI without a known cause, and the patient has AFib. Now, getting into a neurologist with this specialty is rather difficult, and is this worth pursuing?
Yeah. So even in my practice, I will often leave the diagnosis at MCI without going further. At least I used to before these medications were available. But I think, I mean, I can't give medical advice on a patient that I don't know, but I think if there's concern, then take that concern to the doctor. And sometimes you just have to ask that pointed question, which is, hey, what's causing this MCI? Is it caused by something vascular, like related to the AFib, or might it be caused by something else? Now, as I mentioned earlier, these infusions we talked about, I won't treat someone who is on a blood thinner for atrial fibrillation. If you're on Coumadin, Eliquis, Xarelto, whatever, those make, in my mind, make the side effects too great for these drugs. So if one is not going to come off of a blood thinner because the AFib is not going away, I could see that it may not change management in the end by digging further into cause. But I think if there's a question, go ahead and ask the doctor and keep asking until you get an answer you're comfortable with.
I also think that there's, two sides to look at it, where the one side is the medical workup, and is there value in seeing a neurologist when there's a diagnosis of MCI with no known cause. It also is the perfect time to have family interventions, really important conversations about estate planning, about values and preferences when it comes to long-term care, aging in place, naming healthcare agents, having conversations with your spouse or partner or adult children about things that matter to you. If there comes a day where you need to retire from driving, how should that conversation go? And what are some alternatives and kind of conversations along those lines? So that is really a good time, when you're seeking the medical workup, but also at the same time, kind of a parallel pathway with having those important conversations and reflections with yourself and your family.
And that's a great point, Melissa. And as you notice, I didn't touch on that at all. And it's not because I disagree. I fully agree. But the physicians, we don't always, at times tight. And we don't always get to that. And so I think those are excellent points that really should happen quite regularly. But they don't happen often in my practice and other practices as well. But again, I suggest advocating for yourselves, for your family, speaking up, and take extra visits if that's what it takes to get the questions answered.
If you don't mind, can we stick to these? If you could write it down, please, we'll be glad to include it. This caregiving spouse asks, my husband is showing signs of mild cognitive impairment. Tests such as psychoneurological and MRIs have come back negative and not leading to any kind of diagnosis, but his condition is getting worse. What are the next steps that this person should take?
So I'm going to say once more, I'm not here to give medical advice. I can't. I don't know individuals. So everything I say and have said and will say, it can't be used as medical advice. But, that being said, I would suggest that neuropsych testing is really pretty good at identifying objective cognitive changes, language, memory, visual spatial, problem solving in particular, but it's not perfect. It doesn't speak to certain medical conditions very well. It may not speak to personality changes due to pain, stress, whatever. It doesn't always speak to the psychiatric things very well. And so on one hand, it may be reassuring that the tests come back negative, but you can't argue with what you might see that's changing. Unfortunately, medicine doesn't always provide a way to get that diagnosis at the very beginning of a cognitive disorder. Sometimes it takes time. And I know it's difficult, that's frustrating, but there are cases we've seen at UT, my other office, where where we believe something's happening, but we just can't prove what it is yet. And so we repeat the test after 6 months, 12 months, 18 months, and then we might pick it up eventually. But yeah, at the same time, in that time period, you might want to explore with your current doctor, with other doctors, what might be going that's not neurological that might mimic a cognitive disorder. Maybe it is sleep that won't be picked up on the neuropsych tests or an MRI of the brain, medications and whatnot. So there are a couple different paths to take, but I would see some reassurance the tests are looking all right.
We've received a number of questions regarding communicating with a care receiver or transitioning a care receiver. Just to summarize, how do we communicate with somebody, like for instance, moving into assisted living when they don't want to go, or communicating with somebody who can't remember their dad's death, and feeling like we're doing it all wrong when we want to tell the truth, you know?
Those are really common questions that I get asked every day when I'm doing counseling with family caregivers. And it's really difficult because you're there in the thick of things and you have a personal relationship with them. And so you have history, and it can be so difficult to answer the same question over and over and over again, hundreds of times in the same day. And also have that feeling of, well, am I doing it right? Is this what I'm supposed to be doing? Should I be doing something differently? And I think generally speaking, we recommend a joining and validating approach. So that means not correcting them, not arguing with them, not telling them that they're wrong, and just joining with them in their reality, and then validating them, talking about the emotional side of things, and then distracting them to something different. That takes a lot of practice. I find that in my office that it's the most difficult for spouses who've been married a long time. We have this sense of, I can't lie to my spouse. And so we have this sort of internal dilemma about, what do I do? How do I manage this when I want to tell them the truth, but maybe the most loving thing to do is to not tell them the truth and join with them. And so if that's the question that you're wondering, I would encourage you just to try it out. Sort of the nice side about the memory loss is if it doesn't go well, they're not going to remember it later. And so I would encourage you to role play, experiment with it, see what feels right to you, practice, talk with a counselor about it. But in general, without knowing the specifics, that's my recommendation, is to join with them in their reality. Don't correct them. Don't get into arguments, because even if you convince them in that moment and you've come to the same agreement, they're not going to remember it an hour later, and you're going to have the same conversation over and over again.
I don't have a whole lot to add to that, so I won't. That was very, very good.
After transitioning a care receiver to long-term care or assisted living, is it important to work with specialists such as neurologists or any other doctors that they had been seeing or might be seeing? Because sometimes, you know, in the assisted living communities, they'll prescribe meds, and just trying to decipher this here. Can the facility's doctor be enough, or the RN or the nurse practitioner?
Yeah, often they can. I see my role, not a unique role. Other neurologists can do this, but I see what I can add. In particular, is helping to get that right diagnosis, get the right plan, get moving in the right direction early on. As many of these diseases progress, whether it's Alzheimer's or frontotemporal or Lewy body or whatever, often the very same needs come up for all of them. And at some point, it doesn't really matter which of these diagnoses it is, because you're going to do the same thing in the facility. And so I often don't follow a lot of patients once they move into a place like that. A disadvantage that I have is that I usually don't go into the facility to see with my own eyes what's happening. It's often too disruptive to the patient to bring them out, confuse them by taking them to my office and sitting in the lobby or to UT with, you know, big busy places. So it often is better for the patient to keep them where they are. And the doctors and facilities, they often go there and they often see people in the element. They can talk to the staff readily who are all around. Now, if you think things aren't going well, if you have questions, again, voice your questions, voice your concerns. But I do think it's okay for many of the times for people not to see the specialists once they get to a certain point. Now, I think the exception are the geriatric psychiatrists, because they can often add a degree of knowledge about these psych meds over the facility doctors, over the neurologists. And so if behaviors are particularly challenging, there may need to be a geriatric psychiatrist in the mix somehow. But otherwise, I generally have pretty good faith in the doctors who work at these places.
I would add that when someone is transitioning to assisted living or memory care, that as a family member, you still remain as their strongest and biggest advocate. And you still have a very important role to play, even though they have other people caring for them day to day, especially when it comes to medication management. Stay on top of the medication list. I see it all the time where someone moves into a facility and the medications get changed, medications get accidentally dropped off. So staying on top of an active and current medication list is really important. A lot of palliative care services can be offered in assisted living and memory care, and they're very underutilized. And so accessing palliative care, oftentimes they have agencies that will come visit them and provide an extra set of eyes and ears. Also thinking about if you see a dramatic change, that's something to bring to the attention of either their primary care or the RN or the physician there that's not always caught. It's very common for older adults to get things like UTIs. It can cause a sudden acute change. And so I just want to emphasize that even though a loved one is, when they've transitioned, that you still have a very important role to play to be staying on top of those things and in that role.
Why do so many doctors or other practitioners prescribe antipsychotics for dementia or for people who experience dementia? Can this contribute to or exacerbate the symptoms of dementia?
So I can't speak to other doctors other than the ones I work closely with. I think most who prescribe those medications, and I do, would say that that's not our first choice. We'd rather not feel the need to prescribe antipsychotics. There are risks associated with these medicines, but there are risks of safety risks sometimes to the patients and family members if behaviors get too severe. And so I think it's a matter of what's the urgency of the situation. Is there time to try something more mild, maybe more benign? Or is there a crisis that you need to do something immediately before somebody gets hurt? And these medicines, they work pretty well in alleviating certain behaviors. They can cause more confusion. They certainly can. So we try to use the lowest dose of the right medication for the particular person. But as many of you may or may not know, it's a bit of a guessing game sometimes as to how someone's going to react to a particular medicine. There are 5 or 10, sometimes 15 medicines in a particular family, and a couple may work well, a couple may work poorly, and a bunch may work kind of so-so. And we do our best to try to match the right ones to the right patients, but it's impossible to do it exactly right because there are too many unknowns. And so I think it's a good question. I don't think there's a great single answer to it, but I would just reiterate that we like to use lowest dose necessary. And I would suggest if an antipsychotic is used, we try to use it for as little as time at the lowest dose as you can.
We've also received a number of questions regarding family communication, specifically dealing with denial. This person asks, say if your father is diagnosed with Alzheimer's or any type of dementia, and he says, well, maybe I'll get better, even though he knows deep down that he won't. How does one respond to that, and how does one communicate in a very positive way, but also let them know what the truth is? You know, keeping within their reality.
Mm-hmm.
Yeah.
So there's actually a medical term called anosognosia, which I think Dr. Bertelson referenced, that they forget how forgetful they are. That's a symptom of Alzheimer's disease for many patients, is that they lack insight. They don't know the extent of their memory problems. No matter what you do, no matter how many times you have the same conversation, you're not going to be able to convince them. And sometimes that can be more harmful than it is beneficial. And so you have to ask yourself the question, well, why is it so important to me or to someone else in my family to convince them that they have dementia? Who is that benefiting? And what is the importance of that? And so I think thinking about people being in denial, are they actually in denial, or is it a symptom of their disease? And then when it comes to family communication, I was telling some people earlier, I call it the California sibling syndrome, where you have a sibling that lives, no state in particular, but a sibling that lives out of state that is, telling you what you should do, what you shouldn't do, you're not doing things right. And they're not there day to day to see the challenges that you're facing and the amazing job that you're trying to do. And so that is the root of a lot of family communication issues and conflicts, is when you have multiple caregivers involved. Not all are living in state, or maybe they are living in the same city, but it's a really difficult thing. We all come to this disease with different biases, different attitudes, different ways of approaching things. And that's when a counselor can be extremely important in getting everyone on the same page and determining how can we work together to mutually support this patient.
Yeah. No, I agree completely. The anosognosia, or the lack of awareness into one's disease, is very common, especially in Alzheimer's, especially once you get into the dementia stages. In fact, I often use that as one of kind of my internal criteria to determine has a person moved on to being considered demented, because that usually in my experience goes hand in hand. Now, the only, well, there are many exceptions, but there are times where people realize there's a problem. Usually it's in the earlier stages, and it may be fear that causes them to not want to admit there's a problem. It's scary. It's scary to realize that your mind is slipping, especially if you saw that in a family member. And so I think considering where they are in the course of the disease and trying to get a sense, is it awareness, is it fear, or lack of awareness, is it fear, or something else, and really try to address the component of what's causing that behavior.
Just have a few more questions, and just cognizant of your time this afternoon. So this one person describes PTSD. Their care receiver has PTSD, which is he's also diagnosed with dementia. And how does this person take care of this person who continually acts out their anger and maybe has the PTSD continues to exacerbate the dementia?
Yeah, I think whether it's PTSD or the dementia, or PTSD plus dementia or dementia itself, first you have to ask what's the safety concern? Is there something that has to be done emergently? Is someone going to get hurt? And if there's a safety concern, you need to get help right away. I don't have a great answer as to how to address the PTSD specific component or contributing factor to their dementia. PTSD it can be horrible. It can be very distressing to all parties involved. I think if there's PTSD plus dementia, really that sort of person should get help from psychiatry and probably counseling as well, especially if the PTSD or if the dementia is early enough to where they saw some awareness as what's going on.
Mm-hmm. I agree. I think that it is really important to see a counselor that's trauma informed to help that caregiver or the care receiver, if they're in the early stages, being able to possibly have treatment for their PTSD if possible. And then thinking about what are the triggers. There are a lot of things that can cause PTSD, but are there things in the environment that are triggering the PTSD? For example, having the news on all day long. For people who are war veterans, seeing all these images on the news, scrolling, that can be a trigger for them because it feels very present. It brings them right back to being in those war zone periods, and that can cause PTSD symptoms. So thinking about, are there things in the environment that you can change to at least lessen some of those triggers?
So if one's seeing a neurologist and has a diagnosis of dementia, how often should they see their neurologist?
Yeah, it depends. There's no single answer to that. It depends on what help you're getting from someone else, from other, is there a counselor involved? How helpful is primary care? How quickly are things changing? Is one on all the medications reasonably available anyway? What more can the neurologist do? And so it really is, that's very, very case dependent. I don't think there's a clear answer for that. It may be anywhere from every 3 months to once a year to as needed. I can't say more specifically than that.
Does the reduction of is it amyloid? Amyloid. Reduction of amyloid in the brain reverse the effects at all, or just slow the progression? And regarding graphs that depict a 6-month slowdown, suggests that it merely slows the progression.
That's right. Removing amyloid from the brain does not halt the disease in the tracks. It does not bring things back. It slows things down.
With an MCI diagnosis, how long should donepezil and memantine, okay, how long should they be continued? After 4 years, is it worth it to continue these medications, or have they outlived their help?
Yeah, again, every case is different, but I generally keep these medicines on board for quite a while. And the reason is I've seen many cases where the patient is slipping, as we know they will. Medicines are stopped because someone assumes they're not helping, and medicines are stopped and people can really drop down pretty quickly. In hindsight, you realize, okay, it was helping more than we knew, that the disease is just progressing. And the medicine is not able to counter that. So if the medicine's causing a problem, I think that's one thing. I certainly would advocate for stopping something that's causing a problem. But if I say just be prepared that if memantine or donepezil or ribostigmine or razidine, any of these are stopped years into the disease, things can get worse, and they can get worse pretty quickly. Now, sometimes you resume the medicine and you can kind of get back to where you were before. But yeah, so I usually continue for quite a while.
So I'm caring with someone with dementia. How should one deal with the technology, such as computers or remote controls or smartphones, anything like that, especially when you're working with someone who is very technical savvy and was, probably by profession and education, a very, very intelligent person, but now cannot operate such things that would be simple for most of us?
Yeah, I would say simplify things as much as possible. And I mean, there are ways that people can stay connected through a tablet or a smartphone or something that is more simplified. Our gadgets are becoming so complicated, even without cognitive impairment. It's extremely, you give me a new remote control for the TV and it's going to take me weeks to learn how to use it. Yeah. And then you ask someone who has cognitive impairment, who has a difficult time with executive functioning and memory, it's going to be even more challenging. So in my mind, I think simplifying the environment, making changes, because all it's going to cause is increased frustration for them. And then it's going to cause irritability and tension between the care receiver and the caregiver at home. And when you think about how often we use a tablet or smartphone or TV remote control. And so I would say trying to find alternatives, keeping a master list of passwords. For example, I see a lot of challenges with getting locked out of accounts and then having to change passwords. And so having a caregiver that kind of manages things online and has a master list of passwords can be helpful.
And get a teenager, because they can do it all.
This next question is about the consistency of care, or communication with care providers. So what is the gold standard of care for an Alzheimer's patient? Do we need a neurologist, any kind of a specialist, general practitioner, or any other functional medical groups, or cardiologist? How do we coordinate the care and then have that consistency and communicate between medical providers?
Coordination of care in this country is not great. Doctors' offices are not in the same system. They don't usually share the same electronic health record. It's challenging. We still receive faxes from one doctor's office to the other. Handwritten notes, although not so common, still come through. And so communication between doctors' offices, there's not a single solution for that. And despite billions of dollars being put into that and try to increase interoperability, it's still a problem. Not to suggest anyone leave primary care, but if the specialists and primary care are all in the same system, like Ascension Seton or Baylor Scott and White or UT, that does help, because at least you can log in and see what's going on with other providers. But the communication, it's challenging in terms of what's the standard of care, or what's the gold standard rather for the types of doctors. It depends. A lot of primary care doctors are very good at dementia. If you happen to buy online the textbooks, the Harrison's is kind of the gold standard textbook for internal medicine. There are tons of pages in that textbook about dementia, Alzheimer's, and Lewy body and everything else. And so internal medicine, family medicine, they do get experience with caring for and diagnosing dementia. So I would give primary care first pass, a first shot to do what they can do. There are not enough neurologists in town to manage to diagnose everyone who's out there. There are certainly not enough behavioral neurologists out there to do this for everybody. So just realistically, start with primary care. Let's see what they can do. And Alyssa raised a mic, so I'm going to see what she has to say.
I would just add that I am a huge advocate for care management organizations. We have a number of wonderful care management organizations here in Austin that can help you with the coordination of care, even as far as attending doctor's visits, specialist visits when you're not able to go. They can take notes, they can talk with you about it afterwards, and they can be extremely helpful in coordinating care, especially if you're seeing multiple specialists and, primary care plus, 3 or 4 specialists. It can be extremely valuable to have the support of a care management organization. I think sometimes palliative care can be kind of the glue for all of the specialties too, if someone is eligible for palliative care, not to be confused with hospice. And so if you're thinking about palliative care, it's someone who has a chronic condition, any stage, any age. And so that can be a very valuable practice too, to help you kind of link all of the missing pieces together. When I think of gold standards or whatever for dementia care, I think that the social services often get left out. I think that we are such a medical model focused culture that we get very fixated on finding, the best neurologist or the best geriatrician or best internal medicine. And I also think that some of the best advice and guidance and support that are available for caregivers are the people vending right here in this room. The Alzheimer's Association, Age of Central Texas, the home services agencies, home care, all of those folks are going to be able to support you on the journey in a way that just can't be managed in a medical model. And so I think it has to be done in tandem. Get a good medical team, but also build a really strong social support services team around you too to help.
That is an excellent point. There's only so much the physician can do, the PAs, the mid-level nurse practitioners, the medical model. And early on, really through entire lifespan of this disease, there are stresses that are managed best by the support team, social work, care managers, whatnot. So, and y'all are better at that. And many of those things than the physicians are. So talking about where to go, who's the best for many of the family support services and caregiver support, it is the support team, social work.
Yeah, it's a team effort.
Last question, probably a very important one, but I might even know the answer to this one. How does a moderate amount of beer or wine affect Alzheimer's? And can we still have a nip now and then?
So we'll define moderate later. But I wouldn't have a problem with a nip. Now, a nip can sometimes lead to larger amounts if there's a history of abuse. So I think one needs to know where the limits can be drawn. And one problem with being forgetful is you might honestly go back for that second, third, fourth, fifth class thinking that's the first one. And that's, sometimes
We see it a lot in our practice.
yeah, and some may try to game that, but it's really true. The forgetfulness can be a problem. People go over and over and over again. Now, what's too much? I think clearly too much is if you see X amount of alcohol starts causing slurred speech, balance problems, whatever else. So that's clearly too much. In terms of occasionally drinking maybe half that amount, I don't think I have a problem with that with the average person.
Yeah, I agree. Everything in moderation, and thinking about sometimes that's the way that we connect socially. Maybe that's always been your habit. You and your spouse or partner have a drink with dinner and that kind of thing. And so I've never heard any of our physicians recommend no alcohol unless it's been a problem or it's being abused. So everything in moderation.
All right, ladies and gentlemen, please give a warm thank you to Dr. Bertelson and Alyssa.